COVID. It's 4 hours, so please have the two chairperson in mind during this never-ending 4 hours. I'm Marco Ranieri, and I have the pleasure to chair this section with Rafael Bedenes from Spain. The first speaker is Dr. Nuala Meyer. Immune profiling could identify severity. Please.
Thank you so much, and thank you for the invitation to speak. Let's see. I'm not quite, there we go. Okay, a few disclosures, none of which I think pose a conflict. So the things I'd like to discuss with you today are to describe some of our work profiling our large sepsis cohort, which pivoted rapidly to COVID in 2020. And to go through with you both our whole blood and lymphocyte immune profiling, to describe how we found a very high proportion of hospitalized subjects elaborated high titers of autoantibodies. We'll discuss the plasma proteome and then just try to consider the implications of this immune response heterogeneity. So I imagine, just like me, many of you lived through caring for these critically ill patients. And I'd like to just try to get us back to remembering what it was like in those very early days. So in Philadelphia, where I practice, it was mid to late March, and we had been able to watch our colleagues in New York and before that in China and Italy really grapple with the pandemic. But it was really an environment of so much uncertainty where we really didn't know how different COVID would be from our other forms of viral sepsis and ARDS. And as I mentioned, we had that lead time watching our neighbors, especially in New York, as New York started to become overwhelmed with COVID. We had a few weeks to really think about what we could do to prepare. And since my group directs a large cohort study of patients with sepsis, we were able to fairly rapidly make some collaborations with some excellent immunologists at Penn to expand our cohort beyond what we typically do, which involves carefully phenotyping the patients clinically, collecting blood for mostly proteomics, DNA, and RNA work. But we expanded to actually harvest whole blood and then peripheral blood mononuclear cells to really try to understand the immune response. And that's what I'll share with you today. First, just a word on our cohort. So we enrolled just under 450 subjects in about the 2.5 years that COVID was very active. You can see there that the racial disparity of this pandemic in the United States, at least in an urban population, was really dramatic. And maybe to make that point really clear, compared to our typical sepsis population called MESI, where approximately 30% of our patients are Black, in COVID, we saw a total reversal where 60% of the patients we were caring for and enrolling into this observational cohort were Black. We also saw almost a doubling of patients of Hispanic ethnicity that were enrolled to the cohort. You know, we observed things that others have reported on, that Apache probably doesn't really capture the severity of these patients. So Apache was actually slightly lower than what we would typically see in our predominantly bacterial sepsis. And the proportion of ARDS was actually not all that different if you required the presence of an endotracheal tube, but when you diagnosed ARDS in the presence of high flow oxygen or non-invasive ventilation, it was 60% of the population met that. And so in our first 35 or so subjects, we performed high dimensional profiling first of the whole blood. And so just to orient you a little bit, the first two for each of these slides, HD means healthy donors. So patients who at this point had never been exposed to COVID donated their blood and compared it to our hospitalized COVID patients, most of whom were in the intensive care unit. I'm showing you what's called a TSNE, or T-stochastic neighbor representation, a TSNE plot. And TSNE basically clusters like with like, so you get a sense for how many populations do I have. And I think you can appreciate that compared to the healthy donors, COVID patients had this big expansion of the black cells. Those are neutrophils. And of course, we all saw that in our patients, a real neutrophil predominance. And if we gated our flow cytometry to remove the neutrophils and then focused on the remaining white blood cells, some other differences emerge. So maybe there's a contraction of our green and purple populations compared to normal, and those are our T cells, with the purple being kind of those CD8 T cells in purple and in orange. You also appreciate the emergence of a new population in red that we hadn't previously really appreciated at all in ambulatory patients, and these were plasmablasts. And it was really quite striking. I think I was actually on service in the ICU when these first batch of data came in. And what really jumped out to us was that some patients had over 40% of their B cells were plasmablasts. And this plasmablasts are the precursor cell that produces antibodies. Typically, plasmablasts are present in the circulation very briefly. So after a vaccine, for only hours, might you see a spike of plasmablasts. There are other severe viruses, so dengue and Ebola are also very notable for the plasmablast proportion. Interestingly, although these are the antibody-producing cells, we did not see an association between the proportion of plasmablasts and your SARS-CoV-2 spike-specific IgG or IgM, which made us wonder if there could possibly be off-target expansion of this B cell, and what might the consequence of that be. So collaborating with some great immunopathologists, as I said, at Penn, one of our immunopathologists did ANA testing on our hospitalized inpatients. And depending on the cutoff of ANA used, it was about 10% of patients who would meet a clinical ANA threshold of kind of 1 to 80 here in red, but almost a quarter had slightly lower, like 1 to 40 positive ANA. We then went on and did an array of autoantibodies. So this is a busy slide that I'll try to walk through quickly. But what I'm showing you are, this is basically an array of antibodies, of antigens that are self. So healthy, normal people, kind of here in the center, fewer than 15% of us will have any antibody to a self-antigen. And when we do, it's often anti-endocrine antibodies, like anti-thyroid antibodies. Autoimmune patients, shown down here, will have autoantigens detected and often kind of clustered near those that we've implicated in some of our autoimmune diseases. And I should mention that each time we see a red block, that's when the patient's plasma had greater than 5 standard deviations titer of antibody to that antigen, with each patient being a horizontal row. So then if we compare our healthy subjects, in whom rarely we have one autoantibody, our COVID subjects had this really dramatic upregulation of antibodies to self-antigens. And most of those were not to our autoimmune implicated antibodies, but especially to anti-cytokines, some to anti-interferons. And I think this slide also shows you the dramatic heterogeneity. It really was not one specific species of antigen that people made antibodies to, but it was very diverse. And the function of these different antibodies is quite diverse, where some do block the cytokines function and others do not. Okay, so moving away from the plasma back to our profiling, we then took a deeper dive at our lymphocyte population, our peripheral blood mononuclear cells, with a focus on profiling our B and T cells. Just for kind of orientation, for each plot subsequently, green are those healthy donors. Blue were subjects who experienced mild COVID as outpatients, were symptomatic, donated their blood approximately 2 to 4 weeks after COVID. And in red are our hospitalized COVID subjects. With the scale, darker red meant higher on the WHO severity score. So the very dark, unfortunately, means expired. The dark maroon is someone on mechanical ventilation or advanced support, and kind of progressively lighter as your COVID is less severe. And if we just, again, look at our mononuclear cell patterns and compare the red hospitalized inpatients with COVID to either healthy donors or those recovered mild donors, I think you can appreciate that both B and T cells are dramatically reduced. So that was the lymphopenia that we all appreciated clinically. And perhaps the CD8 lymphopenia was even more dramatic than the CD4 lymphopenia, at least in this first alpha wave that we experienced. Kind of up here in the corner, I'm also showing you something similar to the Tisney plot. Again, kind of an overall representation of all these different immune features. And I would just like you to take away the point that COVID, hospitalized COVID, looks so different from healthy donors or recovered donors. And a week later, when we resampled subjects, the profile looked very similar in this hospitalized population. We then started to look a little more closely at kind of what were the features of these different B and T cells so that we could try to understand how they were responding to the virus. And we noticed that many of the patients' T cells expressed really dramatically high proportions of activated T cells. Using the markers of HLA-DR, CD38, double positive. Many of these patients really upregulated that population of activated T cells. They also had markers for active T cell proliferation with Ki-67, and perhaps exhaustion with high markers for PD-1. And while we saw that within patients, their CD4 activation profile and their CD8 activation profile often were quite correlated, we also saw just a lot of heterogeneity, where some patients had very little activation here, low on, this is proliferation, Ki-67, and on activation, whereas others were very dramatic. So we tried to integrate this heterogeneity, and now what I'm trying to do is take our roughly 200 immune features when you take about 35 different antibodies and look at different combinations. That gives you maybe 200 immune features on these peripheral blood mononuclear cells. And we try to project that data, very high dimensional data, into two-dimensional space. And this is called a UMAP plot. And again, it gives you a very high-level view of like from unlike, and you can see that the healthy donors and recovered donors clustered very similarly, whereas our hospitalized patients were quite distinct. And then hopefully the slides project enough that we can also maybe appreciate that gradation of the deeper red clustering farther along the x-axis. So kind of our most severe patients by the WHO scale at the time that blood was drawn seemed to cluster to the far right on the x-axis. However, they're pretty distributed on the y-axis, if we call that component 2. And so we could use these patterns to perhaps group our patients into 3 different clusters, one of which was really dominated by the healthies. We did have maybe 2 inpatients that clustered there. I did a lot of the consenting for this study, so I can tell you One of these two subjects was COVID positive, but very asymptomatic. He was intoxicated, and it was early days, and we didn't really have a good discharge plan for him while he was COVID positive, so maybe it's not surprising that he looked like a healthy or recovered donor. But many of the patients in this plot, some were on room air, some had very minimal symptoms, and some, of course, had very severe pneumonia. So we tried to integrate that into these three immunotypes with their immune features, and I'd say the feature that was most associated with that severity scale along the x-axis was this highly activated CD4 and CD8 cell. Perhaps slightly higher plasmablast response, but we did see the plasmablast response across the severity spectrum. And perhaps that y-axis that I showed you on the UMAP was more what we called component 2 or immunotype 2, where there were some features that might be a more balanced immune response, where you're starting to make memory cells, which might be good to prevent the subsequent reinfection. So I think throughout this conference, we'll hear a lot about treatable traits, and so I wanted to ask myself, could this COVID immunotype be a treatable trait? And as we think about treatable traits, I think the features we'd like a trait to have is that it be relevant. Here we think ours is relevant and that it was highly associated with severity. Measurable in the lab. This was not a qualified flow cytometric test, but the real question, is it treatable, is an unanswered question. We are trying to generate some data in that front within the I-SPY COVID trial. But certainly, as of right now, I would say no, we don't have a treatment based on your immunotype. I'll close by just describing a little bit of our proteomic work. So in the same population of patients, we did a fairly large-scale proteomic screen of about 700 proteins. And we compared our hospitalized patients who we would call moderate, so anywhere WHO scale 3 or 4, sick enough to be hospitalized, but not requiring oxygen, or if requiring oxygen, only low flow, compared to our patients who needed advanced oxygen support or mechanical ventilation. And as I mentioned, we did over 700 proteins, and over 160 of those proteins met false discovery rate for significance. And 160 proteins is still a bit unwieldy. So this work led by Christopher Koskreff, who's now a fellow at Mass General Hospital, used some machine learning techniques, especially elastic net regression, to ask which features were perhaps most important in that severity score. And he could integrate those to generate a severity score. And when he looked at the severity score, both in our population and then in data that Mass General Hospital has made publicly available with their Olink data set, he was really able to replicate the ability of this protein severity scale to predict severity at day 28. And we called you severe at day 28 if you still required high flow oxygen, mechanical ventilation, or if you had died from COVID. So we were happy with this replication, fairly good performance. But perhaps more interestingly, when we then, again, these are observational data, but when we looked at the relationship between receipt of corticosteroids, because the majority of this population was enrolled before the publication of recovery, and use of steroids was quite heterogeneous in our cohort. When we looked at the relationship between corticosteroid receipt and predicted mortality, there appeared to be an interaction where patients with a low protein severity score, I'm showing you risk the protein severity score, those patients with a low predicted severity had a lower mortality if they did not receive steroids, and then less difference at the high end of the severity scale, suggesting that patients who were, by their protein score, predicted to be low severity were harmed by steroids. Okay, I'll finish there just to say kind of what we've learned. The host response is highly variable. We've seen some of the features that associate with severe disease. And I think our next steps are really to integrate multiple lines of data so we can start testing response to treatments. Thank you.
Thank you. Questions from the audience? Now, hopefully COVID is over. How do you project these results to non-COVID ARDS, non-COVID pneumonia?
It's a great question. I think the big question I have is whether this T-cell activation is equally seen in other forms of ARDS and whether that might be some of our target. I'm also hoping that we can use our data and that heterogeneous receipt of steroids to really identify what is the signature of steroid receipt, and can we learn how steroids are helping patients, since we now finally have a mortality benefit in an ARDS population.
Thank you very much. We move on.
It's a pleasure to introduce the next speaker. For Lieuwe Bos from Amsterdam, a better understanding of immunomodulation. Thank you so much for coming, and the floor is yours.
Thank you. So my name is Lieuwe Bos from Amsterdam. It's a pleasure to present on a better understanding of immunomodulation. Let me see if this works. I'm merely presenting on behalf of my team, the best PhD students and postdocs in Europe and maybe even the world. And they do all the big work, and I'm just here to take the credit. So before I start talking about immunomodulation, I would like to make the point that we are not talking about all the immunosuppressive medications that we are used to have in, for example, autoimmune diseases. But in many of these diseases, we have moved away from general immunosuppression towards more targeted treatment effects, for example, by TNF inhibiting, IL-6 receptor blockade. And these are much more targeted and selective and do not suppress the whole immune system, but rather redirect the immune response in the direction we want to move to. And this is an important distinction when talking about immunomodulation in the intensive care unit as well. We have a ton of targets that we can hit with all the drugs that have been developed for several autoimmune diseases. Many of you will now recognize these treatments because of COVID. For example, we have the JAK-STAT inhibitors with baricitinib and the IL-6 receptor inhibitor, tocilizumab. And what we knew before COVID is that if you injure an animal, for example, you give a lung injury to a rodent, it's very easy to treat that. If we give antibiotics, we give mechanical ventilation, we administer vasopressors, and we give almost any type of immune modulation, this animal does not have to die of severe progressive respiratory failure. But lung injury in humans is almost impossible to treat. We use lung protective mechanical ventilation, and we sort of wait until the body resolves it itself. So I think today I have 3 lessons from COVID that we can try to appreciate in the next slides, but if you're dozing away, it's okay if you just remember these 3 points. So I think one of the things we learned is that immunomodulators can influence mortality in homogeneous populations. And with the right tools, we can even predict what treatments might be effective in the near future. And we can also use the example of COVID, that we can learn to understand treatment mechanisms and why certain treatments work in our population. So to go into the first point. So this is a very nice article summarizing all the different immunomodulatory or immunopathologies seen in COVID-19 from a year ago. And by now, we have positive studies for inhibition of these processes on multiple points. Activation of the complement system, there are a few contradictory studies, but at least one of the trials was positive. JAK-STAT, IL-6 receptor, and IL-1 receptor were positive in one or more studies. Endothelial activation could be inhibited with imatinib, and heparin worked in certain subsets of the population that were not admitted to the ICU. So we have proof that interfering with these pathophysiological mechanisms actually improves outcome in COVID. So did we expect these results? Looking back, one can argue, of course, we already knew there are people who gave tocilizumab to the first patients admitted with COVID to the units. But when we then look back and we make a systematic summary of all the treatments that were proposed, we can come to a very different conclusion, that many of the treatments that were proposed were later found to be ineffective in COVID. So I'm not sure we entirely expected these results. For example, I did not expect the result of IL-6 receptor blockade being effective. Why? Because in one of the early reports published by Dr. Leisman in the Lancet Respiratory Medicine, he showed that patients with severe COVID on the left had much lower levels of IL-6 compared to patients with hypoinflammatory ARDS, sepsis, and cytokine release syndrome. And cytokine release syndrome was typically used as the example why we should give IL-6 receptor blockade in COVID. And I think it's very hard to get to causal relationships from this kind of observational data, because there is so much unmeasured confounding. Sometimes we do not really know whether something directly affects the concentration of the biomarker or the severity. We have no idea about the directionality of the effects. But with the right tools, I think we can learn from COVID and we can start to predict effective treatments. So for example, if we use genetic randomization, we can assess someone's genetic predisposition, evaluate the exposure, in this case to COVID-19, and the severity of COVID-19, either with ICU admission or mortality. And we can eliminate the effect of confounders on the genetic predisposition, because someone was born with it, right? And I think the genomics example in the case of COVID-19, but also the work that the previous speaker, Professor Meyer, did in ARDS, is very important, because using these kind of methods, the investigators from the UK predicted that both IL-6 receptor was important and that TYK2, which is one of the targets of baricitinib, might have been important. Of course, it's not a perfect guess, because one of the other expectations was that interferon treatment might be effective, and it proved to be less likely so. But it is a much better guess than the one we had with the 50 therapies, of which maybe one succeeded. So after we can accept that immunomodulators can influence mortality in homogeneous populations, and that we can predict effective treatments with the right tools, we can move on to the next point. We can understand treatment mechanisms. In order to do so, we again have to drop the observational framework, and we have to try to go to a causal relationship. I mean, causes are very hard to discern in an intensive care unit in such complex circumstances, but there are tools to do so. And one of the strongest tools, beside the random allocation of alleles, of genomic material, is that we randomly assign treatments to patients, which we do in randomized controlled trials. Again, eliminating the relationship between potential confounders and treatment allocation. Now we can evaluate potential mediators. So that means that these are observations, or in this case, biomarkers that are related between the treatments, they are influenced by the treatment, and they in turn influence the outcome, in this case, mortality. So I'm going to show you the data from a randomized controlled trial we did in the Netherlands. This analysis is by Justin de Brabander. In COVID-19 patients admitted to the ward, it's an RCT of oral imatinib versus placebo, and the primary outcome in a long-term follow-up was 90-day mortality. And what's quite unique about this study is that we had biomarkers in almost all of the patients before randomization, at day 2 and at day 5. And we could use this framework that I showed in the previous slide to get to causal relationships. So the total effect in this study, not observing any of these intermediate changes, was a reduction in mortality with a hazard ratio of around 0.5. That persisted up to 90 days. We then evaluated, so that's the total effect, the arrow you see in the bottom. We then evaluated relationship A from the treatment on potential mediators. So does a patient that is randomized to imatinib have a bigger change in biomarkers than a patient randomized to placebo? So I'm going to skip this. So in this study, we evaluated a lot of biomarkers because we were unsure what mechanisms would mediate the effect of imatinib. We did a literature search, we summarized all the potential biomarkers, made an assay of the things we could reliably measure in the plasma of these patients, and then measured all of those biomarkers in all of the patients in all of the time points. And on the left, you see one biomarker, in this case IL-6. The red dots are the patients treated with imatinib. The blue dots are the patients randomized to placebo. And you will appreciate two lines that are slowly diverging over time. This is called an interaction between the treatment effect and the time of exposure. And this treatment effect was significant, quite significant in this study. And it was not only significant for IL-6, but for several other biomarkers that are depicted in red on the right-hand side. Well, this is interesting, but it's not really bringing us any new conclusions or closer to why imatinib is causing a lower mortality. So the next step we had to do is not only model this relationship between imatinib and the biomarker concentration, but now also model the relationship between the change in the biomarker and mortality, which is depicted in C in this figure. And as you can appreciate, an increase in all these biomarkers resulted in an increase in mortality. Now we have a path going from randomization to imatinib to a change in the biomarker concentration to a change in mortality. This path is called the indirect path. It goes through the biomarker. Combining that with the total effect, we can now estimate what the effect of imatinib treatment would be if the IL-6 concentration, for example, would change as if the patient had received placebo. And you can appreciate that the beta approaches 0 for patients treated for the IL-6 effect, which means that if IL-6 was not changed by imatinib but had its natural course, the effect of imatinib on outcome was 0. There was no effect whatsoever. So rephrasing, all of the effect of imatinib was caused by a change in these biomarkers. So if you can start to imagine that although we thought this was primarily a barrier protection agent, we are now starting to figure out that a lot of the other effects that imatinib has are maybe the primary way these components work. So I have 2 more minutes, so I can show you another trial. This is not published yet. Together with our Greek collaborators, we got access to data from another COVID study, this time randomization to anakinra versus placebo in patients with a high SUPAR and COVID-19 admitted to the ward. Again, 90-day mortality, again, biomarkers before randomization, and on sequential day using the same framework. I can now move a little bit faster because, of course, now you have understood all the arrows in this graph. And you can appreciate that if we randomize the patients, we could see the same steeper decrease in IL-6 concentrations in patients treated with anakinra on the left side. We did not have all the other biomarkers, but we could see the same effect for C-reactive protein, which of course is in the pathway of IL-6 activation. When we then repeated the analysis that I showed for imatinib, we found a reduction in IL-6 and CAP after exposure to anakinra, an increase in CAP or IL-6, both resulted in an increase in mortality, and again, the direct effect of the treatment on outcome approached zero, suggesting full mediation through a reduction in IL-6 or CAP. So bringing that all together, I think the three lessons we learned from COVID-19, and I hope I convinced you that these are important points, are immunomodulators can influence mortality in homogeneous populations, and we should not give up on studying these. With the right tools, we can predict effective treatments, but we should lose the associational, observational framework and move towards causal relations. And we can understand treatment mechanisms, but that does require having sequential data and novel analytical approaches in a randomized controlled trial. And I think for me, the main lesson of the last 3 years was that causal inference techniques are essential in getting these high quality data and high quality conclusions. With that, I would be happy to take any questions.
Please, any questions in the audience? Feel free to ask, and you can move to the microphones. Okay, one question on the floor.
Yes, thank you for your presentation. I'm Letali from Erasmus Medical Center. I have a small question. In your study, in your second trial, you mentioned like CRP and interleukin-6 are important biomarker, but in your previous study, I didn't see the CRP. So did you include it, or did not find the association?
No, we did not include CRP. It actually did not meet the standards we had set beforehand for what was an interesting biomarker. And additionally, although it's a readily available lab test, we did not measure it in all our patients in the lab. And the Luminex assay has a slightly different unit, so you cannot even translate the findings in the Luminex assay straight back to the lab test result. So that's why we were a bit hesitant of including it, although I had wished that I would have it in the lab results now.
Yeah, thanks.
Thank you very much. We move on to the next speaker, Dr. Manu Shankar from Edinburgh, the different responses to convalescent plasma therapy.
Good afternoon. Thank you, Chairman, and the conference organizers for this invite. I'm going to talk to you for the next 12 minutes or so about the convalescent plasma therapy. I'm so grateful to the previous speakers to have laid the ground, especially Dr. Meyer, on the immunology of COVID. Just an acknowledgement of my funders. I'm funded through Clinician Scientist Award, and some of the other grants are all public funded grants. I do have a conflict of interest that is intellectual. I run a precision medicine program. I do advisory board activities, but they are not directly linked to this talk that I'm giving, and they are all managed as independent research funds. Again, I want to talk to you about three things here. Building on what Dr. Meyer highlighted about the differences in the immune responses and how they influence treatment, I just want to make one specific point related to cytokines and chemokines and effector responses. I want to kind of talk about why we think about COVID-19 from some of our previous work and why convalescent plasma. So Dr. Meyer had already highlighted to you there is significant immunological heterogeneity. I want to kind of bring in a second concept, which is the types of effector responses. We all have broadly three types of effector responses, which are called type 1, type 2, and type 3. if you follow the slide, just focusing on the middle of the slide, type 1, type 2, and type 3, with a viral infection, you're only expected to get what would be called as a type 1 response. And in a type 1 response, against an intracellular pathogen like virus, you wouldn't expect to see type 2 and type 3. I want to kind of highlight in the next few slides that you are seeing type 2 and type 3 in COVID-19. Early on in the COVID-19 pandemic, when we were thinking about what biomarkers to measure if we were to design a clinical trial, as part of kind of follow-up from this work we published, where we show a few things that is of relevance to the discussion that we're going to have. If you follow the figures, basic schematic of the figure is the same. On the x-axis, you got control patients who are seropositive and seronegative to COVID, and then patients with moderate, low, moderate, and severe COVID-19, and then lower respiratory tract infection, that's viral or bacterial as control. And what you see here is 3 biomarkers, particularly IL-6, IL-10, and IP-10. There is an increase in concentrations with increasing severity of COVID-19, and IP-10 is very characteristically high in COVID-19, particularly severe compared to other viral or bacterial infections, because it's one of the mechanisms by which the virus kind of circumvents the initial host response to infection. And we kind of highlight many of the things that Dr. Meyer talked to you about. I want us to focus on this triad of biomarkers, IL-6, IP-10, and IL-10. And the rest of the immunology is the T cell and the B cell biology that has been described already. In our data, patients with these combinations of biomarkers had a high risk of death and high risk of progression to more severe disease. So early on in the pandemic, when people were thinking about what to intervene with, one of the things that we considered at the time was probably an IL-6 blockade and something to do with IP-10. And the other reason for thinking about convalescent plasma is that a proportion of patients admitted with COVID-19 were seronegative. In other words, if you were to give antibodies, could antibodies improve their outcome? And around the same time, there was a paper that was published by Carolina Lucas from the Ale Impact Study, where they looked at patients with moderate and severe COVID-19 and alongside healthcare workers who are uninfected. I think the only reason I'm highlighting this study is not to go through all the biomarkers listed there, but to make the point that what I highlighted to you earlier as type 1, type 2, and type 3 effector immune responses, these authors beautifully show that early on in COVID-19, as the severity of disease increases, you start to see all 3 types of effector responses. As an example to you, to contextualize, type 2 is what you would see in asthma with raised IL-4 and IL-5, which is not what you would expect to see in a viral infection, but this paper beautifully highlights the breadth of the immune response you see. So around the same time, REMAP-CAP, which I am a part of, we did a biomarker sub-study within the whole REMAP-CAP trial of the convalescent plasma domain. And I'm going to share you the results of the biomarker sub-study after highlighting why it was relevant to do. So as I said to you at the start, convalescent plasma is essentially immunoglobulins that are specific to SARS-CoV-2 infection or any other viral infection. And if you give antibodies, those who are antibody negative would have probably a better treatment response. And even if you're antibody positive, your antibodies may not be specific enough. So someone who's recovered from COVID will have a much more targeted antibody response because your adaptive immune system would have learned from the exposure to the virus. Overall, this trial, we studied around 2,000 patients who were randomized within the convalescent plasma domain. Around 1,000 patients received convalescent plasma, 900 patients received usual care. And the primary outcome of the trial, reported in JAMA, there was no difference in the primary outcome of organ support-free days at 21 days. But as I said to you, there is a relevant hypothesis here to test, which is patients who are antibody negative may have a better treatment response. And we tested that in the main trial when we collected the blood samples. And you see here that overall, there is no difference in the treatment effect if you are antibody positive or negative. And alongside this main trial, we had measured we had collected blood samples to measure additional biomarkers and had hypothesized that patients with convalescent plasma would have a differential treatment effect based on plasma biomarker subphenotype. And we studied patients who are critically ill with COVID-19 who received, as an intervention, 2 units of high-titer convalescent plasma, or the usual care was no convalescent plasma. And because the trial was happening at the same time as pandemic, in steroid domain had completed and most patients got corticosteroids. And the primary outcome was the same as the primary outcome for the REMAP CAP trial, which is organ support 3 days, and the secondary outcome of interest was hospital mortality. And just to briefly say, the patients we studied patients who were randomized within the UK, and out of the UK randomization, we had roughly 58% of patients who got usual care and 72% of patients who got convalescent plasma. And we show this table 1 in the online supplement purely to say that patients were similar across usual care and convalescent plasma, and they were comparable to the overall trial. In other words, what we are observing is likely to be unrelated to baseline differences in patient characteristics other than the biomarker that we measure. So what did we measure? We measured around 28 biomarkers, but 2 of the biomarkers, in particular TGF beta 1 and IL-2, had high missing values, and they were excluded a priori based on the analysis plan that we had set. Those biomarkers with lesser amount of missing values like CCL3, CCL20, and BAF and GM-CSF, we did imputation as based on the GIB sampler left censored missing value imputation. I want to just spend a couple of minutes to just highlight the value of the biomarker panel. So IL-6, I told you earlier that it's prognostic. CXCL10, we highlighted earlier on. And we also kind of talked to you about the type 1 and type 2 effector immune responses, which is IL-4, IL-5 are part of the type 2 effector responses. And within the pandemic, as we were trying to design various studies, we had an altered interferon panel and GM-CSF as an example. And those who are interested in B-cell biology, you see a non-specific early plasmablast response in COVID-19, and we felt that probably it is related to the survival factor. And like Dr. Meyer highlighted, there is autoantibody. So there is a relationship between autoantibody generation and BAF in the immunology literature, and that's a reason for measuring BAF in April. And the analytic plan is fairly simple. It's unsupervised clustering after log2 normalization of the biomarker data. And we identified 3 biomarker-based clusters of patients or subphenotypes, or you could call them subtypes. And these subphenotypes differ in their biomarker profile. Those in red, which is this whole panel, horizontal lines are patients and vertical lines are the biomarkers. And this panel is type 3, where there is high levels of chemokines and inflammatory biomarkers like IL-6. This panel here is the subphenotype 2, where you can see here type 2 responses, which is IL-4, IL-5, and then high levels of GM-CSF and vascular-related biomarkers. And the third larger group of patients is what looked like a generally dysregulated inflammatory response, not kind of targeted responses. And the vector plot on the right-hand side tells you what biomarkers to look for what phenotype. And just to recap the previous figure in a different way, these subphenotypes are different biologically, and they meet almost the definition of a mechanistic endotype because they show consistent patterns with different immune responses that you would expect to see. And the next question we had was, does it relate to some of the seropositive status biomarker associations reported in the literature. And those of you who follow the immunology literature will realize that if you have high levels of CXCL10, IL-10, you are likely to be seronegative. If you have high levels of CCL3, CXCL8, and IL-6, you are likely to be seropositive. And that relationship is true in the overall population, and in this there are some differences within the subphenotypes. So biological possibility number one, the serology works. The second question here is the survival status in the biomarkers. Overall, these patients had higher levels of IL-6, angiopoietin-2, IL-10, which I highlighted earlier on. And that biomarker relationship holds true across the subphenotypes if you were to look at individual values. But what you see here is that if you are critically ill, everybody were critically ill in ICU, the notion that higher IL-6 or higher inflammation will have a higher risk of death no longer holds true, and that's important. The severity biomarkers become less relevant once you're critically ill. But overall, there is plausibility to the observations that we do. Coming on to the treatment effect differences here, it's a fairly simple model of logistic regression. In this case, it's an ordinal logistic regression for the organ support free days. What you see here is subphenotype 2 and 3 no longer benefit from convalescent plasma, and subphenotype 1 probably show a differential treatment effect. In other words, between the subphenotypes, the treatment effects differ. And again, if you got convalescent plasma, subphenotype 2 and 3 had a higher risk of dying, subphenotype 2 did not. So again, a treatment effect heterogeneity based on a biomarker profile. And as part of any work, please don't tweet this slide. It is, we had a validation cohort of biomarkers. We see the 3 subphenotypes with similar biomarker profile and similar characteristics. And in other words, what we are doing currently is to explore the biological mechanisms for these 3 subphenotypes. So there are some strengths and limitations to the work that we did. The strengths being that I don't think you would find a larger RCT cohort with a priori defined biomarkers and an unsupervised analysis. And we show consistently that these are biologically plausible observations, and we think that we can extend it a bit further by providing molecular mechanisms with the work that we are continuing to show that there are some features of endotyping within these biomarkers. Like any study, there are limitations. We didn't have any non-COVID controls, but the goal wasn't to look for non-COVID controls. When we did the study, the population was unvaccinated. It's post-vaccination, so we can't say for certain that these biomarker profiles in the subphenotypes may hold true to the vaccinated patients, but if we just need to do further analysis to see whether that is the case. And the last point was around the definitions. You may think that this is pedantic, but this was a whole debate between us and the reviewers about what do we call this? Do we call this a subphenotype, endotype, or a trait? And we decided to kind of leave it at subphenotype because we didn't feel that we had strong enough mechanistic link in this paper to call it. We should have done it, but there. So I'll leave you with that summary slide. It's published in ICM, and if you want to get in touch about anything, please look down my email. Thank you so much.
Thank you. The paper is open for discussion, questions, comments. Now, how do you think is in the future pandemics with another virus to export the validity of these data? Because they are quite specific with what we observed with one virus. That hopefully is.
Yeah, so I think great question. I think what we are showing here is unlikely to be specific for a viral disease like COVID. It is likely to be common across different critical illness, in particular, anything that involves the respiratory system and causes critical illness. You're likely to see many of these biomarkers. We have data that shows that you can see these biomarkers in children with MIS-C. We have data that show that this is positive in flu. We have similar data in bacterial infections, particularly community-acquired pneumonias. The population where this data doesn't hold true in our hands is the trauma patients and pancreatitis patients, where the degree of inflammation and the early change in the dysregulated immune response pattern may be different. But in all other infections who go on to become critically ill, we see similar patterns.
Thank you very much. If we have no further question, we move on.
Okay. So again, it's a great pleasure to introduce the next speaker, Adrienne Randolph from Critical Care Department of Anesthesia in Boston Children's Hospital. Thank you so much for coming. And the title is, It Was Different in Children?
Thank you. So I don't have any major disclosures, but I do get funding from the U.S. Center for Disease Control for most of the research that we're presenting. So I'm going to talk about acute COVID in children versus adults briefly, and then I'm going to speak mostly about the syndrome that appeared in children called multisystem inflammatory syndrome in children, and how it emerged, and then treatments and potential host susceptibility factors. So I'm first just looking at US children where there was surveillance, but in the UK and in Europe where there was also surveillance, the data looked very similar. It was much milder in children than adults, and although there were a lot of cases, there was very few deaths percentage-wise in the pediatric population. And overall, the mortality rate compared to elderly adults was extremely low. And also the case rate was also very low. You can see that the 0 to 4-year-olds are the orange on the top, and then the 15 to 17-year-olds sort of the dark blue on the top. And those are, really, or it's actually gray on the top. It's a fraction of cases compared to adults. And this was true across the pandemic, even during the Omicron peak, where there were a lot of cases. These are hospitalizations. Now, the truth is, though, that in Omicron, most of the pediatric pediatric population did get exposed and got infected with Omicron, and the number of actual infections outpatient was very high. Now, why were children potentially protected from severe COVID-19? Well, there's multiple potential reasons. No one knows the exact true reason, but one reason is that most of these children had fewer comorbidities, and in fact, the children who did get sick had comorbid conditions, chronic lung disease, neurologic disorders, obesity in the teenagers. Also, they have a reduced expression of ACE2 and a more robust interferon response, especially in the younger children who are the most protected. And also, they have greater amounts of T cells because they have greater thymic output of T cells and T cells that recognize non-structural viral proteins, and less T cell exhaustion, which is what you see in the elderly population. So just going a little bit further into that, there's developmental differences in the immune system between children and adults. And there's higher interferon production, there's adult level interferon production fairly early on. So in early childhood, they reach adult levels of interferon production. It's low in the around birth, but then rises fairly rapidly. However, the antibody responses and the T cell repertoire and T cell function responses need to develop over time by multiple exposures through natural infection or vaccination. But the T regulatory cells are actually at highest numbers in around birth, and then they go down over time, so they're the lowest in the elderly population. Now, so we really don't know exactly why children were protected from severe disease for the most part, especially healthy children. And so people really were, reassured until in early 2020, there was emergence of this life-threatening inflammatory syndrome in children. First, in Italy, it looked like Kawasaki disease, which is a mucocutaneous syndrome, often with skin signs and cracked lips and conjunctivitis and high fever for multiple days, and a lot of inflammation. There was 8 cases of this that then presented in London and then in New York. And so very rapidly, this worldwide alert went out, and there were multiple definitions from the European CDC, the US CDC, and the World Health Organization for this multisystem inflammatory syndrome. Using the CDC definition, which these definitions are fairly similar, the WHO definition is less than 19 years or less and has fever for 3 days or more. But there has to be fever, inflammation, and in the CDC definition, it could be multiple biomarkers, including ferritin, CRP, procalcitonin, neutrophil to lymphocyte ratio, and then multi-system involvement. And the difference between the CDC and the WHO definitions were the CDC allowed respiratory to be one of the systems, which made some overlap with acute COVID cases who had multi-system involvement. And then they had to have exposure to SARS-CoV-2 and no plausible alternative explanation. These patients looked like septic shock patients because a lot of these patients had shock, and it was impossible to tell without ruling out with bacterial cultures that whether or not what was triggering this. So we published a paper pretty rapidly in the pandemic where we already had an ongoing pandemic surveillance project that was we thought we were going to have a flu pandemic, but we moved it into doing surveillance for COVID, and we captured 186 cases, and this was published alongside a publication in New York State of 99 additional cases. So in this issue of the journal, there was about 300 cases, and we took out the New York cases that overlapped with ours. And you can see here that there is a lag between the peak of COVID activity and the emergence of peak of MIS-C activity, and it's a post-infectious syndrome that occurs on average between 3 to 6 weeks after the infection from COVID. Initially in the pandemic, the first year especially, it was affecting even worldwide, mostly minority populations, and this was the US data. There was a predominance more in male than female children. Most of these children were previously healthy, about 80% were previously healthy. And the age range was 8 to 12 years. But the thing that was the peak age range was approximately 8 to 12 years, which is an odd age for things to present because most of those children and other diseases don't usually present in that age range. But what was really concerning, and this is what the concern was with Kawasaki, is Kawasaki disease is the most common cause of acquired heart disease in childhood. It causes vasculitis with coronary artery aneurysms they don't go away quickly. This disease caused in about 10% of patients, which is why everyone was so aggressively treating them and very scared, coronary artery dilations that went away fairly quickly. You can see here that the dilations by 30 days had pretty much resolved on echocardiogram. The other thing is about 40% of the patients or more had impaired left ventricular ejection fraction on echocardiogram. And even the worst impairment, most of them by a month had resolved. And this is a follow-up study we did that we published in JAMA in 2021. But what treatments should we use in this new syndrome? It was mostly driven by what did they use to treat Kawasaki, especially once the aneurysms were seen and people got very scared that there would be a permanent effect on the heart. So IVIG is the first-line treatment for Kawasaki, and some patients get a second dose if they're still febrile, and systemic steroids are often added on in severe cases, and sometimes biologic agents. And so that's what people treated them with. These patients were also very coagulopathic, and so systemic anticoagulation was recommended. This was early in the pandemic, but it pretty much panned out throughout the pandemic. Most of these patients went to the intensive care unit. and about half got vasoactive support. Mechanical ventilation was not as frequent. Mostly it was for cardiac failure, not respiratory, and the mortality rate in this group was really low. So overall, throughout the whole early part to first years of the pandemic, it was less than 2%. Some kids did go on ECMO, mostly for cardiac reasons, and the survival on ECMO was fairly high, and the run of ECMO was pretty short compared to the acute patients that went on to ECMO. So this is a paper that we published. Mary Beth Stone's a rheumatologist. We did a propensity analysis of the patients and looking at treatment and outcomes for multisystem inflammatory syndrome. And at the same time, the BAT study led by Mike Levin in the UK published in the same issue of the journal their results. We found, looking at IVIG and glucocorticoids as initial treatment on day 0 of treatment, that it had less cardiovascular dysfunction 2 or more days later, and less adjunctive therapies were given. But the BAT study had no evidence that it was different from IVIG alone, IVIG plus glucocorticoids, or glucocorticoids alone. This was our data. You could see that for multiple outcomes, and our composite outcome was left ventricular dysfunction and shock, but both were going in that direction. We did 2 types of propensity adjustment, was all going towards that. So we looked at this, why did we get these disparate outcomes? And one thing that, came out was that our patients were much sicker in the US registry, and we used a cardiovascular outcome. And so those who were in the propensity matched were the sickest patients, where the BATs used a composite outcome of mechanical ventilation and death, which was uncommon. So one thing that we did is we did an individual patient meta-analysis, including our study, the BATs, our registry, the BATs registry, and this named O'Dalley's French registry, and that is just accepted to pediatrics, and it also shows early treatment with IVIG plus glucocorticoids on that individual patient meta-analysis was helpful. Now, not all countries can get IVIG, and steroids are an option and should be considered as well. They're much less expensive and much more widely available as first-line treatment. So the other thing that came out in the pandemic was there was a high rate of neurologic involvement. We had a registry where we captured all these patients in the U.S. So we published this in the first year of our first year of the 2020 data, and then we did another one a year later that showed pretty much the same thing with even more encephalitis. But we found that about 22% of these hospitalized patients had neurologic involvement, but most of it was transient and went away. But some of these patients had severe neurologic involvement, with some who died, and then those that survived having sequelae and over half the time. And it was a range of a spectrum of things, including meningoencephalitis, encephalitis, and stroke, encephalopathy, cerebral edema, Guillain-Barré, and sinus venous thrombosis. We saw that as well in the second year. So just look, we also have an immunobiology study, and we are trying to understand what's triggering MIS-C and how it differed from severe COVID. And we had biomarkers and also looked in detail at genetic risk factors, and Janet Chow, also the role of viral variants. Janet Chow did a lot of this work, and we were trying to differentiate. We had a control group of patients who had mild COVID who didn't develop MIS-C. They were outpatients, and those were our controls for MIS-C that we collected their blood 30 days later. And on all the MIS-C patients, we had over approximately 350 that we enrolled. We did whole genome or whole exome, and it's a rare disease. And so we were looking for rare disease variants for hyperinflammation or immune deficiency. And so And then we had to functionally validate them once we found a variant to show that it caused hyperinflammation. So Dr. Chow, who's a pediatric immunologist, she's published some of this work. She did all of these assays and interpreted the whole genomes, her group. And in about 8% of these patients, we found rare heterozygous variants in genes known to be essential to host immunity. Some of these were hyperinflammatory and major pathways she shows here, and these were validated. So overall, I wanted to just thank everybody. This was a huge group effort funded by the CDC, some of the fundings also from NIH, with multidisciplinary group with neuroradiologists, neurologists, cardiologists, rheumatologists, immunologists, critical care, and ID, experts in pediatrics who all work together. And the FDA also worked with us doing a lot of antibody studies. But this syndrome now has gone down to almost nothing. There's almost no MIS-C cases internationally. And it's unclear why. It's probably acquired host immunity from infection and vaccination, as is the speculation. Thank you.
Thank you so much. Any questions? Yeah, we have one question in the audience.
So thank you very much for this presentation. I'm Maya Hitesh from Erasmus Hospital. And okay, I understand that you say that you think that it's due to acquired immunity, but I just have a question. Did you have any possibility to look at maybe families that did COVID? So in the same, because usually if the kids had it, the parents too. And so I don't know if there was, I mean, if you had the possibility of looking to see if there's any kind of signal in family genetics with the immunity?
Yes, so this is one of the things that of these variants, in one of the patients where we found a variant, and it's a known variant, the father also has the variant. That's one of the publications, but he didn't have hyperinflammation in his life. But this child also developed it multiple times, and it needs therapy. And so, the penetrance can be different. And there is a set of brothers who both had MIS-C that we were, that I know of, but as far as there can be multiple children in a family, there's not a lot with multiple children who developed MIS-C. So it's unclear, like, why did one child in a family develop it, not others? Why does somebody carry the same gene variant but didn't, when they got COVID, get really sick with COVID? So it's unclear.
Okay.
Thank you.
So let's move on to the next speaker.
Thank you very much. It's a great pleasure to introduce a very good friend of mine, Alain Combes from Paris, about the heterogeneity of myocarditis. Salut.
Salut Marco, thank you very much. So this is first my disclosure slide. Very soon after we saw the first COVID patients, first of course in China and then in Europe, there were published reports about cardiac injury occurring in patients with severe COVID with very different potential pathogenic mechanism, whether it might have been only a myocardial oxygen supply-demand imbalance, RV dysfunction in the context of severe ARDS, or more specific endothelitis and proagulant activity in these patients leading to a severe vascular disease, not to mention the cytokine storm. But there might also have been direct myocardial injury because of the cytokine storm, maybe because of this diffuse endothelitis, or because of direct lesions to myocardial cells. And the clinician presentations were many from acute cardiac injury only by monitoring an increase in biomarkers, and specifically troponin, or acute coronary syndrome, which were clearly more frequent because of the procoagulant activity during COVID, arrhythmias, acute cardiopulmonal in patients with severe ARDS, thromboembolism also, which were more frequent, especially in the first months of the pandemic, and some patients also who developed clearly signs of classical forms of myocarditis. And once again, these first reports came from China and were mainly focusing on those patients who had biomarkers elevated, was mostly troponin, but there was a price to pay to this increase with a mortality which was up to 50% initially in those first reports for patients who had elevated troponin. So let's have a look now more specifically at myocarditis in the setting of COVID. And once again, during the first weeks of the pandemic, we saw some case reports published about patients who clearly developed what might have been qualified as classical myocarditis with late gadolinium enhancement when performing an MRI, and signs, clinical signs, EKG signs, elevated troponins, which were quite typical of myocarditis without an involvement of coronary artery diseases. We gathered on an international basis in 23 hospitals in the US and Europe cases of clinically suspected COVID-19. Of a population of patients who were close to 60,000 patients hospitalized for COVID, and we identified only 112 patients, and when focusing on clearly identified and well-documented patients, we ended up with 54 patients included in this analysis. So overall, the prevalence was quite low. It was around 2 per 1,000 hospitalization for definite or probable myocarditis. It was a bit more for those patients with possible myocarditis. And well, these are the characteristics, and when looking at the association with pneumonia, most of the patients, actually the majority of the patients, did not have concomitant pneumonia. It was mainly cardiac dysfunction, typical of cardiac myocarditis here, presenting with chest pain in 60% of the patients. There was no other major differences in the initial presentation, looking at dyspnea, fever, cough, which was close to what was reported by most COVID patients. Same for the time interval. This time was a little bit more longer for those patients who had concomitant pneumonia. Troponin was elevated. It's very interesting also, the doctors did not perform a lot of biopsies in these patients. It was only in 30% of the patients, and most of the diagnoses were made by cardiac MRI in these patients. It's clearly now the first line diagnostic tool for myocarditis. LVEF on average was 40%, not that different from patients with or without pneumonia. And almost half of the patients had concomitant pericardial effusion in that series once again. And this is the outcome of these series of patients. Overall hospital mortality was 7%, and it was higher when there was concomitant pneumonia. It was 15 versus 0. And when looking at mortality and the need for mechanical circulatory support, this time it was 10 versus 37 for patients with pneumonia. So let's focus now on the data we have. And once again, not all of these patients got an endomyocardial biopsy. On the data we collected, and which were collected for myocarditis patients, and this is the classical Dallas criteria to grade the severity of myocarditis into negative borderline, with mainly moderate cellular infiltrate and active myocarditis, in which there is a major infiltrate plus signs of myocardial necrosis. And for the first case report we published, there was only moderate lymphocytic infiltrate with rare or sparse areas of necrosis. This is one example here, but it was very frequent in other case report that there was minor, first minor infiltrate and also no signs of necrosis. And most of these patients actually did not have a positive RT-PCR within the myocardium. In some, the PCR was still positive, and the virus was identified using electron microscopy, but not in the myocyte. Most frequently, it was mainly in the interstitial mononuclear cells, as reported here in that just case report. This probably is, as of now, the larger trial of endomyocardial biopsies in these severe suspected COVID myocarditis patients. 104 patients here who did receive an EMB. Age was 58. The median LVEF was around 30%, and most patients were male. And once again, the level of inflammation here was only modest, with most patients having borderline or no signs of severe myocarditis here. And when looking at the RT-PCR, was positive only in 5% of these patients here. For those who had a positive RT-PCR, they also have most frequently an active myocarditis here with some signs of myocardial necrosis. Just one word about vaccination. We all know that vaccination was associated with myocarditis and myopericarditis. This is one of the largest cohort of patients here, more than close to 5 million people in Denmark, which were followed up for 1 month after either the Pfizer or the Moderna RNA vaccine. And of course, there was a higher number of cases here, higher actually with the Moderna as compared to the Pfizer. But the incidence was very low, was 1 to 4 cases per 100,000 vaccinated people, so very, very low. And when looking at the occurrence of cardiac arrest of death, it was actually lower post-vaccination in this cohort of patients. Well, trying to identify the phenotype of myocarditis, we have heard a lot about MIS-C, the multisystem inflammatory syndrome in children, which was also reported during the first and second, third waves of the pandemic here, with very specific involvement of the skin lymphadenopathy and a huge inflammation ongoing also in these patients, and also cardiac involvement with decreased ejection fraction in virtually half of these patients, not that severe. Only here 4% of the patients needed ECMO for the most severe forms of cardiac failure, and the number of children with an ejection fraction below 50 was only 1/3. But we also have seen some adult patients developing this multisystem inflammatory syndrome. This is one patient we treated in my ICU here, the first one, 27, when once again the typical form involving the skin, and also here the inflammation within the eyes, and these patients also developed severe myocarditis and needed the VA ECMO support for 4 days with complete recovery. So reviewed all the cases of fulminant myocarditis were hospitalized in our ICU, which is 26 beds, which is also a MECMO referral center for the whole Greater Paris, both for respiratory and cardiac failure. And we identified up to the end of 21, 38 patients who were hospitalized here for fulminant myocarditis. Was mostly men, and 66% of those patients qualified for the multisystem inflammatory syndrome. They were quite sick, but once again, we are a referral center for the most severe forms, so the LVEF was 20% on average. Only 1/3 of these patients had concomitant pneumonia at the time of the diagnosis. Most of them got an MRI which showed mostly edema, but only 50% of them got late gadolinium enhancement. And we did perform a biopsy in only 3 of these patients, and was negative in one, mildly positive in the other one, and highly positive with both active infiltrate plus myocyte necrosis in the third one. Almost half of them needed VA ECMO support for a median time of 7 days, and the overall survival was quite good at 84% here, but we're talking about young patients here. So when looking here now at the differences between those patients who had the multi-system inflammatory syndrome, the MIS-A plus patients, these are the typical features here. The time from COVID to myocarditis was obviously longer for the multi-system inflammatory syndrome patients, and they tended to be less sick when they were hospitalized for myocarditis. The SOFA was almost half in these patients, and obviously the positivity of PCR was much higher for myocarditis patients, the true one, as compared to the MIS-A plus patients, and those patients had obviously a higher rate of positive serology. Inflammation was also much higher in the MIS-A plus patients. And then we did a principal component analysis of blood cytokines to qualify the severity and the profile of these patients. And actually there was striking differences between the two populations of patients. The MIS-A plus patients had mostly elevated IL-17 and 22, which are cytokines which are involved in mucosal and epithelial innate immunity, when the patients who had the classical form of myocarditis had more higher level of interferon alpha, IL-8 and I1 beta, which are more typical of antiviral and pro-inflammatory profile. And when adding to these variable, the clinical variable, the MIS-A negative patients at a positivity for RNA pulse 3 antibodies, O2 antibodies, which is typical of systemic sclerosis. And we have also shown that it's highly elevated in flu-induced myocarditis patients. So it was just similar here in these patients. Same for the more fulminant forms and more need for VA ECMO. And obviously MIS-A plus patients are significant signs of inflammation plus positive serology and more skin involvement. In ICU mortality was much higher for the classical form of myocarditis as compared to the MIS-A plus patients. There was only one out of the 25 patients with MIS-A plus who died, and the mortality was 31 for these other patients. So here is the summary of the differences between these two groups of patients here, with the MIS-A plus having more on late signs. Positive PCR was more frequent with the MIS-A negative, as the serology was more frequent for the MIS-A plus, more systemic inflammation, skin involvement, maybe less myocardial dysfunction for MIS-A plus, and probably also a better prognosis here. And when looking at biopsies, once again, we did not perform a lot of biopsies here, but the MIS-A plus patients had clearly a different disease here, which much less infiltrate of cells, and maybe more an inflammatory syndrome linked to cytokine storms or whatever we don't really know. And regarding the treatment, this has been discussed previously, mainly involving steroids plus IVIGs and the classical supportive care of the patients in the ICU. So, well, first, myocarditis was quite rare, and probably less frequent as compared to H1N1 patients, for example. And we clearly have here two entities, the MIS-A plus, which is a post-infectious disease, which is completely different from the early fulminant cases, which once again had these RNA pulse 3 antibodies. And it appears that many of the published cases of fulminant myocarditis were probably actually MIS-A plus patients and not true acute myocarditis patients with the classical form involving inflammation with T cells and signs of myocyte necrosis. Thank you so much.
Thank you. The paper is open for discussion, questions, comments. You mentioned at a certain point a time evolution in the clinical manifestation of this and others entity. And in general, with COVID, we experienced this. I mean, as time went by, we saw the evolution. Would you like to put this in context?
So as mentioned in the previous talk, this is something we almost never see now. We have seen some flu-induced myocarditis this winter, but no longer myocarditis related to COVID. So it actually has changed over the months and years of the COVID pandemic, and probably with much less MIS A+ inflammatory syndrome in the late phase, and let's say when the Omicron came. There might be also a different tropism of the Omicron, which is mostly involving the upper airways and maybe less frequently the lungs and maybe also the hearts.
Okay, if no further comments, thank you very much. And I keep presenting very good friend of mine, so it's my pleasure now to introduce Matteo Bassetti from Genoa, Italy, who is very happy because his football team is about to be promoted in the first division. Giusto, Matteo?
So we hope so. Thank you very much for your introduction. My task today is discussing with you about how the epidemiology of bacterial infections has been affected by COVID. And as you can see in my presentation, there has been a lot of changes in the circulation of bacteria in our hospitals. So these are my disclosures. But let's start talking about my talk today. So I will cover three points. First of all, general epidemiology about bacterial infection in general. What about resistance, and then what about the impact of COVID on that? So let's start with the general epidemiology. So general epidemiology changed in the past 20 years. So if we compare the study, the EPIC-2 study published in 2010 by Jean-Louis Vincent, the predominant pathogen in general in the ICU was Pseudomonas aeruginosa, followed by E. coli and then Klebsiella. If you look at the data 10 years later, so Pseudomonas aeruginosa remain at 16%, but you can see the increased role of Klebsiella pneumonia that is actually predominant with more than 18% or 80% of all the cases. If we compare the last available data regarding bacteremia in the ICU, and I look at the study Aerobac2, you can see very well the different bugs. We have Pseudomonas, E. coli, Klebsiella, and Acinetobacter, and you can see very well that actually in the Aerobac2 study, Klebsiella is the predominant bug with around 28% of the isolates over the bacteremia, followed by Acinetobacter baumannii and then by E. coli, and at the last point, Pseudomonas aeruginosa. So the situation completely changed regarding Pseudomonas. It was absolutely the leader till at least 10 years ago. So when you look deeply at pneumonia, and this is a nice study in the ICU looking at the role of the different pathogens, you can see very well that if we split hospital-acquired pneumonia and ventilator-associated pneumonia, you still see that Pseudomonas aeruginosa is not anymore the predominant pathogen, even in pneumonia. So Enterobacterales represent the main pathogen with around 20% in hospital-acquired pneumonia and more than 25% in ventilator-associated pneumonia, followed by Staphylococcus aureus, that is the second pathogen, and then we have Pseudomonas aeruginosa. So what do we know about resistance? How resistant has been changed recently. So when we look at the impact of antimicrobial resistance, so this is a nice article published at the beginning of the last year in Lancet, and there was a surveillance about the global impact on death attributable to and associated with bacterial antimicrobial resistance. And you can see that the top impact on number of deaths in terms of associated or attributable to resistance was represented by low respiratory tract infections, followed by bloodstream infection, and then intra-abdominal infections. But it's interesting to see that when we go in detail of the different pathogen in terms of impact on mortality, the first pathogen is represented by E. coli in terms of number of deaths and impact on resistance, followed by Staphylococcus aureus. And then, as you can see, now we have Klebsiella. So Klebsiella is a recurrent pathogen, very important in our hospitals. So when you look at the burden of infections from bacteria with resistance in the European Union, you can see that Eiger is the color to red. Eiger is the problem in terms of resistance rate, and you can see that the Eastern European countries, Greece and Italy, are actually the countries with the higher incidence of antimicrobial resistant strains. So these are actually the problems in our hospitals, not only in Italy, but in many other countries. The emerging of carbapenemases, particularly in gram-negatives. So everybody probably knows about Klebsiella and about KPC, that is one of the main mechanisms of resistance. But then we have the metallo-beta-lactamases, IMP and VIM in Pseudomonas aeruginosa. And then we have the metallo-beta-lactamases, other type like the VIM and NDM in other enterics like E. coli, Klebsiella, and other Enterobacterales. And then we have all the OXA 23, 24, and 58 in Acinetobacter baumannii, and the OXA 48. It is quite common even in Europe in Klebsiella and in E. coli. So obviously, this different mechanism of resistance means resistant not only to carbapenems, but also to many other antibiotics, including the new antibacterials. So when you look at the proportion of carbapenem resistance, look at the last available data from the EuroBac2 trial, and you can see that in Klebsiella, actually, around 40% of the Klebsiella are resistant to carbapenems. When you look in Pseudomonas aeruginosa in the ICU, around 33%, but look in Acinetobacter, almost all Acinetobacter baumannii are now resistant to carbapenems, and we are close to more than 80%, closing to 90%. So, when you look at the situation regarding the Klebsiella pneumonia and the resistance to third-generation cephalosporins, look at the situation all over the world. There is no one country around the world that is not affected by the resistance to third-generation cephalosporins. So you know what does mean the red in Russia? Means 80% of the Klebsiella pneumonia isolates that are resistant to third-generation cephalosporins. And look how many countries are red-colored. You know, you can see India, for instance, many African countries. So actually, third-generation cephalosporins are not anymore the drugs in the majority of the country for treating Klebsiella and even E. coli. And this is the situation regarding the resistance to carbapenems in Klebsiella. These are the data that show, as I mentioned before, that Romania, Greece, and Italy are more affected than any other country for this resistance to carbapenems. And this is the situation regarding Pseudomonas aeruginosa, again resistant to carbapenems. Here the situation is a little bit better, but for how long will be better? I don't know, probably if I will come next year, situation will be probably more problematic than the year before in terms of resistance to carbapenems. And then this is the situation regarding Acinetobacter baumannii. So you can see very well, this is the situation all over the world. Look again, the purple color means more than 80% of the strains resistant to carbapenems. And the last point is MRSA. Is MRSA, still MRSA, a problematic bacteria in all over the world? And my answer is yes. There are countries in which MRSA is declining, countries in which they did a good job in terms of infection control, like UK, north of Europe, but there are other countries in which MRSA is still a very important bug. You can see very well the situation in Africa, but look all the situation in Asia. I mean, I refer to China, India, and many other countries. So the last point that I like to cover is the impact of COVID on that. So how COVID impact on resistance. So, and unfortunately, I would say that we use too many antibiotics in our hospitals, in our ICU in general. So this is more than 80% of the COVID patients receive empirical antibiotic therapy during the hospital stay. More than 92% of the patients in the ICU receive antibiotics. And obviously, the rationale for using antibiotics, at least in the first period, was probably related to the anxiety about immortality, but actually is not anymore justified. So in 2022, in 2021, using antibiotics in all the patients in the ICU with COVID is not anymore justified by any guidelines all over the world. Because there is a low median rates of bacterial co-infection or superinfections, and this contrasts sharply with the antibiotic exposure. However, unfortunately, due to the COVID, we go back of probably 20 years before. This was an editorial written by my friends Jan de Walle, in which together we say antimicrobial stewardship in the ICU during the COVID pandemic back to the 90s. I would say back to the 80s. So we lost 30 years of efforts in antimicrobial stewardship. This is just an example. This is a survey conducted in Lombardia region in which they analyze the number of hospitals that suspended or reduced antimicrobial stewardship. 88% during the COVID period, and look how many start again with the antimicrobial stewardship program, only 23% of the centers. And this is the results. When you look at in a survey conducted in Lombardia in 18 centers, multi-drug resistant hospital-acquired infections outbreak in 88.9% of the centers. And look the box, multi-drug resistant Acinetobacter baumannii, multi-drug resistant Pseudomonas aeruginosa. So when we look at some examples, again, from my country, this is the situation regarding the impact of Klebsiella pneumonia, carbapenem resistant colonizations in the ICU, and look at the number. So this was the situation before 2019, and look in 2020. So there was an explosion of numbers of colonizations, and then obviously of infection in the ICU. So when you look at the impact of resistant infections in COVID-19 patients, overall, this was a nice meta-analysis published last year, and overall the patients in the ICU present in 27% of the cases resistant bugs. So resistant bugs were particularly important in patients with COVID-19. So looking at the specific studies conducted during the COVID-19 pandemic, and this is a nice study from my country, from Pascale, and published last year, and they analyzed the carbapenem-resistant bacteria in an intensive care unit during the coronavirus pandemic, and this is a multi-center before and after cross-sectional studies. And looking at the bug, no impact, you can see before and after on carbapenem-resistant Klebsiella, you can see here the data, but look at the impact of Acinetobacter baumannii. So there was 5 infection over 10,000 patient days, and there was 7.5 folds increase in the number of infections by Acinetobacter baumannii. And looking at the different mechanisms of resistance, you can see no increase in KPC, but increase in OXA48, in VIM, and in NDM, that are very difficult to treat mechanisms of resistance. This is an experience in my hospital that we published in 2010 related to the first wave of COVID. And look how many, this was conducted in the ICU, look how many cases of colonization of infection by carbaresistant. 12 infection by carbaresistant Pseudomonas, 6 infection by Candida auris, and 2 infection of Klebsiella pneumonia carbaresistant. So, unfortunately, there has been, during the COVID, an alarming increase in the rates of infections since the previous year, with rates of carbapenem-resistant Enterobacteriales up to 35% and carbapenem-resistant Acinetobacter by 78%. And this is an alarming, and in fact the alarming comes from the CDC, and the CDC released a couple of months ago this report about resistant bugs, and you can see the main increase was in carbapenem-resistant Enterobacteriales, with around increasing 35% of hospital-acquired infections between 2019 and 2020, and the same for extended spectrum beta-lactamases. Here, the problem is not only in the hospital, but even in the community, because we use too much antibiotics, not only in hospital, not only in the ICU, but even in the community all over the world. And these are the results: a dramatic increase in resistant and in resistant strains. I believe this was my last slide, just some recommendation about rational use, but this was more important during the COVID-19 pandemic, and now the COVID-19 pandemic is end, and probably these suggestions are not anymore actual. Thank you for your attention.
Thank you, Matteo. Questions, comments? Now, Matteo, I mean, it might be, it's always something that I have in mind. Is it possible, I have actually two questions. First, it is possible that the color codes that you presented all over the world is somehow related to the available resources in terms of ICU beds, step up, step down unit, I mean, organization in general terms, the first question. The second question is, what do you think about alternative approach to treatment for these patients? Is antibiotic the only approach to kill a bacteria? I mean, there is a growing field of research in this, and I would like to have your comment, because, I mean...
So regarding the first question, definitely yes. Countries with problem in terms of organization in the hospital, that means in general also no adequate attention to the infection control procedures. That means obviously also having more nurses, more doctors, and more education, are in general countries with a higher incidence of resistant bugs. So this is true. The red countries are in general the countries that are not so deeply involved in infection control and all the rules that we know very well that they work. So regarding the second question, so I would love to change the paradigm of treatment of bacterial infections. However, we don't have actually data that support monoclonal antibodies or bacteriophages or other type of treatment. So what I think that what we have to change is not the type of treatment. I mean, we know that bacterial infections must be treated with antibiotics. What we have to change in the future is try to have more diagnosis. So using more and more diagnostics. So till now, we are still using in the majority of the patients in the ICU empirical therapy. So I grew up in an ICU center 25 years ago, in which my mentor said, oh, in 2020, there will be not anymore empirical therapy. And we are in 2020. And 85–90% of patients in the ICU are treated with empirical therapy. We have to move to the target therapy with the new diagnostic tools.
Thank you very much. Now your time.
Okay, thank you, Dr. Bassetti. So let's move on with the next speaker is Dr. Joost Wiersinga from the Division of Infectious Disease of the University of Amsterdam about antivirals. Thank you so much for coming.
Yeah, thank you very much, Mr. Chairman, ladies and gentlemen. It's a real pleasure to be here. And I prepared some slides about antivirals. And I think we have learned a lot about COVID-19, and certainly on the field of the discovery and implementation of all those novel anti-SARS-CoV-2 agents. I think that's really nice to see. These are my disclosures. And here I just made one slide of an overview of currently used therapies for COVID-19, and that's still counting. On the left side, you see the early interventions we have that are targeting the virus SARS-CoV-2. And on the right side, you see an overview of treatments for the more inflammatory response of the disease. So I will focus for this talk on the left side. And here you see totally on the left side, all the SARS-CoV-2 monoclonal neutralizing antibodies that have been developed and used all over the world. You also see those small molecule antivirals. Remdesivir, of course, is a really important one. Molnupiravir, nirmatrelvir, boosted by ritonavir, and the new ones, ensitrelvir, and an oral remdesivir analog that is coming up. And of course, the interferon medications that also have this effect on the inflammatory response. So let me first start with a short review of what can we do in hospitalized patients. And a lot have been published about it. I just would like to focus on remdesivir, because it is in all the guidelines that in patients hospitalized on the wards, certainly remdesivir is being advised. This is evidence from one of the latest updates of the large WHO Solidarity trial. For 14,000 patients across the globe, and here it was focused on what is the evidence that remdesivir really works in these patients, and when we look at the outcome of mortality. And across a lot of studies, it has been shown that in those patients that are already ventilated, are already treated on the ICU, no effect can be seen of the use of remdesivir. The same is in those patients which have no oxygen initially needed, but in the middle group here depicted in red, in those patients which are not ventilated but are treated on the wards with oxygen, there is this clear effect of remdesivir on mortality. And here you see in this series that the remdesivir group, it was 40.6% mortality, and in the controls 16.3%. So that is like an absolute mortality drop of 2%. I also like these schemes included in these papers. Here you see the effect of, on the upper side of the Solidarity trial, but then also they did a meta-analysis of all these trials on remdesivir in hospitalized patients, which did show mixed results. But then again, you really do see this effect on mortality in those patients treated with oxygen on the ward. However, we can of course ask ourselves the question, how big is this effect? So what is the number needed to treat of patients to save one life? And I think that's really a lot. And is it really cost effective? Of course, also, a lot of these studies were performed in a different area in which different variants were there, and also in which a lot of people were not fully vaccinated yet. Then you can also give other antiviral drugs in your patients. So the first trials and the first studies on the use of nirmatrelvir, ritonavir in hospitalized patients, they were not positive. Some were stopped. This is just the newest, just published in Annals of Internal Medicine, and this is a retrospective cohort of 16,000 patients who were hospitalized with COVID in Hong Kong during the Omicron period, just last year. And here it was seen that molnupiravir and also nirmatrelvir, ritonavir, they did have an effect on all-cause mortality in both the vaccinated and unvaccinated hospitalized patients, but there was no difference on the effect on ICU admission, yes or no. And like all those studies, it was seen that nirmatrelvir, ritonavir was a little bit more effective. Retrospective data, and of course also here the question on which patients would really benefit the most, and are you also does it also work in patients that are already up to 7-10 days into the years, which is, I think, still a question mark. Much more data of these novel antivirals about the prevention of hospital admission. Let me just show this one, again on remdesivir, published last year, in which remdesivir could be used to prevent progression to severe COVID in patients, outpatients. And here it was 562 outpatients. It was given within 7 days of onset of complaints. Also higher risk patients, so with higher risk of disease progression, with comorbidities, higher age, etc. And in a lot of those studies, the endpoint is prevention of hospitalization for COVID or death at 28 days. And intravenous remdesivir for 3 days was better than a placebo in this setup. It occurred, the endpoint is in 0.7% of the intervention and 5.3% in the control group. Then again, here you want to give a patient 3 days in a row IV remdesivir to save on hospitalization. So if this is logistically feasible, and certainly if it's cost effective, that's of course a big question mark. Then we have seen the studies on nirmatrelvir, the Hammond New England study. It was really effective during the Delta period, but does it still is useful during the Omicron surge? I think this is also a beautiful setup of this study. It's from Israel, in which they could gather a cohort of more than 100,000 patients. And then they looked at those patients that received nirmatrelvir, ritonavir, 4%, and then they used a Cox proportional hazard regression model to see what was the effect of nirmatrelvir. They could again see, like in the earlier studies, that nirmatrelvir was associated with a diminished rate of hospitalization, but the effect was less than during the original studies, and also it only seemed to work in the higher, in the older patients, who of course are more at risk for hospitalization, so in patients 65 years or older. Then what about the early treatment with neutralizing SARS-CoV-2 monoclonal antibodies? So this session is also about what did we learn from COVID. Well, I become very enthusiastic about the development of all these monoclonal antibodies against infectious diseases. It really opened up this whole field. So we did have those monoclonal antibodies for C. diff infection, also for anthrax it was developed. But now you saw in suddenly the surge of so many new approved monoclonal antibodies, and just one of the latest additions is this beautiful one, a monoclonal antibody that's effective against malaria, and I think also that you can also use for preventive measurements in travelers. But anyway, the focus is COVID, so sorry about that. Another beautiful example is this one, in which you can give a cocktail of SARS-CoV-2 neutralizing monoclonal antibodies with prolonged half-life. So imagine that you have a patient immunocompromised, vaccinations do not really work in that particular patient, and perhaps before the COVID season you could give a shot of such an intramuscular given monoclonal antibody cocktail to prevent COVID-19. Large study has been done and it did work. However, again, number need to treat it very high, so which patient population would be nice, and the most important thing, of course, the influence of the novel SARS-CoV-2 variants. I like this editorial in Nature, in which they call all these novel Omicron variants just the COVID variant soup, which makes it quite difficult to predict the responses to vaccination, to treatment, and also what's the course of all these winter surges. So it's a sentence from one of those articles. The Omicron lineage of SARS-CoV-2 continues to evolve successively, yielding subvariants that are not only more transmissible, but are also more evasive to antibodies. So they just don't work anymore as good as they were. This is a New England paper of Takashita, who has regular updates in which he investigates the neutralization activity of all those novel antiviral SARS-CoV-2 agents. On the left side, you see all those often used monoclonals against SARS-CoV-2, and you see that you really need very high doses to have any neutralization against SARS-CoV-2. So for most instances, they just don't work anymore. On the right side, you see remdesivir, molnupiravir, and nirmatrelvir. They are not affected by these different variants. This is a study of our own group in which we also looked in patients who were treated with such a neutralizing monoclonal antibody against SARS-CoV-2. In our setting, those are mostly the really severely immunocompromised patients from hematology, oncology, nephrology clinics, etc. But what we did see in this group, that in up to 50% of patients, you saw the emergence of resistance mutations during treatment. So that means that resistance occurs already in your patients while you're treating the patient, and that was associated with the delayed time to viral clearance. So on the one hand, that's not good, of course, for the patient you're treated, but it could also be potentially harmful if such a novel mutant will circulate in the wider community. So I would like to show 3 slides about, with all this information, what is the current recommendations of the guidelines. I show the WHO one and the one of the NIH. Here you see the just updated March 6 guidelines of the NIH for non-hospitalized adults with COVID-19. In those patients who are at risk for disease progression, the elderly, comorbidities, there, ritonavir boosted nirmatrelvir is the #1 choice. Remdesivir is also mentioned over there. Then, in those patients with severe COVID-19 who are hospitalized, then in those patients who are not mechanically ventilated, remdesivir is advised. Those guidelines always differ a little bit. Here you see the WHO living guidelines. This is a January 2023 update. And you see non-severe, severe, and critical COVID-19. I focus here on the non-severe cases. Then again, also in those patients with risk factors for disease progression, nirmatrelvir, ritonavir is the #1 choice. And then what's new is that also in the shared decision-making process for during pregnancy, it also seems to be safe to give that. Molnupiravir, really a weak recommendation, and remdesivir in non-severe, severe COVID as an weak or conditional recommendation. But you also see a strong recommendation against the use of convalescent plasma and against the use of neutralizing SARS-CoV-2 monoclonal antibodies because of the diminished neutralization of currently circulating SARS-CoV-2 variants. So that's not anymore recommended. Of course, in certain cases, in patients who cannot clear the virus, who are immunocompromised, there can always be, perhaps in your selected patients, a good case to make it, but not in, it's not in the guidelines anymore. So what's coming? Just 2 last slides. I like this recent example published in New England about pegylated interferon lambda for COVID prevention, early treatment. So in high risk, mostly vaccinated outpatients with less than 7 days of symptoms in Brazil and Canada, 40% had the Omicron, you did see that helped, and that changed the endpoint a little bit compared with the previous studies, hospitalization or emergency department visit. But then again, for this intervention, you also need to treat a lot of patients to prevent one hospitalization or ED visit. These are also 2 novel developments. And siltavir is a SARS-CoV-2 protease inhibitor. It seems to be well tolerated. It does have a clear effect on positive effect on viral clearance. And I think also a very nice development that you now have this oral remdesivir, this oral remdesivir analog, VV116, and that was a New England paper recently published in which they compared it not with placebo, but with nirmatrelvir ritonavir, and it had similar test characteristics in a large cohort. So this is my last slide. I started with an overview of currently used SARS-CoV-2 antivirals. I think when you look at the guidelines, there's not so much place anymore for the monoclonal antibodies. It's nice that for the small molecule antivirals, we do have these new treatments that are coming, and of course also for the prevention, the interferon. But for all these novel agents, it is really the question for which patients would it be mostly, who would benefit most? Will it be cost effective in your setting? New things, could we combine perhaps different of these treatments in a given patient? And availability of these drugs is really different across the globe. All right, I would like to thank you very much for your attention.
Please, any questions in the audience? So I would like to ask you some things. So there are open questions for the future, right? But just quick questions. So do you feel comfortable with the update recommendation of the WHO guidelines regarding antibodies or antivirals? Do you feel comfortable with this, the role?
Yes, I think for the large part, I think the guideline committees did a good job. So for one instance, the remdesivir. I practice in the Netherlands, and in the Dutch guidelines, remdesivir is not recommended to use in patients admitted in the hospital on the ward. And why? Well, the guideline committee says, well, yeah, there is this clear effect on mortality, but the absolute difference of just 2%, that does not make it cost effective. So when sometimes I do prescribe remdesivir to the patient admitted, but then the costs are for our own hospital division. So there are some clear differences there. So I think there's also now with moving from Delta to Omicron, that there's also the danger of overtreatment.
Okay, so thank you so much. So let's move on with the next speaker. So I would like to introduce the next speaker, Professor Anthony Gordon, Chair of Anesthesia and Critical Care, talking about other ICU treatments. And thanks again for coming.
No, thank you for the invitation. So I'm talking to you about other ICU treatments, a big topic. My disclosures and acknowledgements are shown here, and just to point out that some of the drugs we tested in REMAP-CAP were donated free of charge from the companies, and the views expressed are my own. So when trying to decide which other treatments to talk about, I thought, well, what were the big ticket items that struck us 3 years ago when we first started treating severely ill, critically ill COVID patients? And I think 3 things struck at me was the inflammation, the thrombosis, and the severe hypoxemia we saw in these patients. Now, I believe some of the earlier speakers talked about inflammation, so I'm not going to talk about the anti-inflammatories, the immunotherapies. So I was going to combine 2 treatments around thrombosis, and also then how do we manage that severe hypoxemia? Because I think there was a lot of uncertainty at the beginning of the trial, and maybe now we have learnt more through our trials. So, as we all know, having treated these patients, thrombosis was a major problem in COVID-19. It affected so many of the organs, and it was both venous and arterial thrombosis we were seeing. So whether it was MIs or strokes or pulmonary embolus, DVTs, the hypercoagulable states, I remember the renal replacement filters kept clotting. It was a real challenge how we were going to manage this. And of course, there was a lot of variation in practice, people suggesting all sorts of treatments with this novel disease. And of course, there was an obvious treatment we have. If we see thrombosis, we have got drugs. We have heparin. It's antithrombotic. People were also suggested maybe it would be antiviral and anti-inflammatory again, so there could be benefits. But And I remember in a grand rounds in our institution in early 2020 when we had seen these thrombosis and saying we were going to test heparin in the REMAP-CAP trial, I remember senior colleagues saying, really? You can see the clots, we have the treatment, surely we should just anticoagulate the severely ill patients. We thought that it needed to be tested in trials, and thankfully we weren't the only people in REMAP-CAP. Our Canadian colleagues in ATTACK and our US colleagues, it is the Active 4A group, also said, we think it should be tested in a trial. And rather than run 3 entirely separate trials, we said, let's join together, harmonize our protocols, bring them together into this multi-platform trial and analyze them together. So if there is important signals there, we can get answers as quickly as possible. We did that, and you'll know we got answers that were published simultaneously in the New England Journal around the critically ill patients and the non-critically ill patients. There were always planned to be 2 different analyses, and it turned out to be, as you will heard from the opening session, an important distinction we made. So we set the trials up to give different answers in these different states, what we call the severe state, the critically ill patients on ICU having organ support. And we hit a trigger. Remember, in these trials, we're using a Bayesian design, so no fixed sample size. They read out when they hit the predefined triggers. And it hit the predefined trigger of futility. 99.9% probability that it was ineffective. That's an odds ratio less than 1.2. The way our model works, odds ratio above 1 is good. More survival, more days alive and free of organ support, because our primary outcome is organ support-free days. And hopefully you see this, the dark red is the deaths, and then in the survivors, how many days alive they have free of organ support. So a high number, the blue is the good result. And you can see that there is no big difference. If anything, there's a reasonably high probability, 95% probability, that is actually harmful, giving full dose, therapeutic dose heparin compared to a normal prophylactic dose, whichever your site gave. So many sites had already switched to intermediate doses. And then shortly after, we were surprised to find out that in the moderately ill patients, these are on the ward, we saw exactly the opposite effect. We'd stopped now because we hit the superiority trigger, 99% probability that giving therapeutic dose heparin was better. Now you use the same outcome, you can see they're less sick patients. So fewer deaths, more patients without any organ support. But again, there is a difference here, and when you look at it, it's about a 4% absolute difference in the risk of dying or requiring organ support. So important and maybe surprising results that we weren't expecting. Now, those of you in the opening ceremony will have seen we've now analyzed that data in using more sophisticated techniques, looking for this heterogeneity of treatment effect. Ewan Gallagher presented it, and you can see when you consider the risk of the patients, here, those at lower risk of dying get the most benefit from the drug, whereas actually once they become more severely ill, it results, and actually there's a greater risk of them being harmed. This is above in organ support-free days, and the bottom one is sort of showing similar results, but in terms of hospital survival. So that is heparin. We also had other antithrombotic anticoagulants, antiplatelets. Again, there was a good rationale biologically why they may be important and involved in inflammation, as well as their effect in the clotting cascades. And we again thought, well, which drugs would be best? We didn't know. Would it be simple, cheap, easily available aspirin? Or do we need other antiplatelets, the P2Y12 inhibitors? And again, we said, well, there's a lot of practice around the world, and people made arguments for whether which P2Y12 was their favorite, which was most likely to be a benefit. And we kept it as pragmatic, and we said, well, sites can choose whichever one they want to use. Most use clopidogrel. Again, we gave the treatments while they were in hospital. We tried to make it safe, ensuring gastric protection, and exclude patients at high risk of bleeding. And here, again, we saw the results using organ support-free days. This is just in the REMAP-CAP trial. And Bayesian designs allows multiple comparisons to happen. And actually, first of all, the model told us that aspirin and P2Y12 inhibitors have very similar effects. And we hit this trigger here early on in the trial. And so we planned prospectively before we read out that we would pull the analysis combining aspirin and clopidogrel. Then we hit our futility trigger again. There was no big difference between the drugs you see here, more than 95% probability of that being hitting our futility trigger. But I will just point out when you look at the red here, there is a slight difference here in the short-term survival in favor of the P2Y12 inhibitor. But we'd stopped for our futility. But we've now just published in January of this year in JAMA our long-term follow-up of, for these domains that have concluded earlier in the pandemic. And here I show you the 6-month follow-up of the antiplatelets. Again, as I said, we've pulled the antiplatelets. And you can see that this mortality figure I talked about maybe just starting to appear at hospital discharge is maintained over that 6-month period, such that there's a reasonably high probability that for long-term survival, maybe antiplatelet drugs have some benefit. And it's not just survival. In our 6-month follow-up, we also did health-related quality of life and disability assessments. And just on the top row, you can see for the anti-inflammatory, going back, IL-6 receptor antagonists, high probabilities of increased survival and quality of life in their survivals. But I've highlighted with the box here, when you look at the antiplatelet therapies here, really high probabilities that when you look at death and quality of life in those survivors, really high chance of benefit here. Let's get this right. There you are. 99.6% probability of improved outcomes. And if you confine it to just the survivors, so ignoring all the deaths, you can still see there's an improved quality of life in those survivors. So very interesting results. The antiplatelet drugs seem to be having an effect in the long term, but not in the short term. How do we explain that? I'm not sure I know the answer. But it is interesting, obviously, with the design of REMAP-CAP, it was multifactorial, so we actually randomized patients to both. And if you think back, I'm sure your hospital may have included patients who got both heparin and antiplatelets. People were so concerned about the thrombosis. We saw this effect when we looked at those patients who got just prophylactic dose heparin and aspirins. I keep pressing the wrong button, sorry. You can see there was a sign that these patients were the ones benefiting. If they actually got therapeutic dose heparin and an antiplatelet drug, it was these patients that seemed to be harmed. I suppose we would think, well, I'm not surprised, giving 2 drugs to prevent clotting, there may be a risk of bleeding. The risk of bleeding actually doesn't seem so high, so I'm not sure we can explain it all by bleeding. But certainly the idea of what treatments for giving the right treatment to the right patient and maybe not combining them is important. What about other trials? The recovery trial tested aspirin in a huge study, 14,000 patients, and they reported no difference in the 28 days, so short-term mortalities. Although there was a statistically significant, although small difference, with more patients leaving hospital alive again on the aspirin. And if you consider their sicker patients, because the majority of their patients were on the ward, there actually was, when you look at the patients on non-invasive or invasive ventilation, the risk ratio is 0.95 in favor of aspirin. So maybe there's a small effect, and I hope they will publish their long-term outcomes soon, and we will see if confirm if there is a long-term benefit from the antiplatelet drugs for the COVID patients. Just going through other trials, the Active-4A, just to summarize, they gave P2Y12 inhibitors and heparin, and again, this combination wasn't beneficial. If anything, again, a small signal for harm. So finally, to talk about oxygen therapy again, what was the best way to treat patients before they get intubated? Should they get intubated early? Should we use non-invasive ventilation? Would it cause infection control issues, aerosol generating procedures? Again, no one knew the answer. And if you don't know the answer, run a trial, randomize patients and learn. And so this was run by my colleagues in the UK, Danny McCauley and Gavin Perkins, the Recovery RS trial. And they randomized adult patients who were hypoxemic on more than 40% oxygen and SATs below 94. And they randomized them to one of three arms, to get CPAP, high flow nasal oxygen, or just to stay on conventional oxygen therapy until they needed intubation. It was pragmatic, or how you ran those interventions was left to individual sites. And their primary outcome was a composite of both requiring either invasive ventilation or dying within 30 days. They plan to recruit up to 4,000 patients, and you can see the recruitment over time here as the different waves came in. But by the end of the spring of April 2021, recruitment had dropped, and I think they decided then to stop because it was going to be impossible to recruit large numbers of patients from that point onwards. And just to point out, the trial was designed that they would compare each of the interventions against the control rather than against each other. So they had a shared control group with close to 400 patients in each group. Describing those patients, they were on more than 60% oxygen, SATs at 93, and half of them were proned. And the treatments they got was a mean CPAP of around about 8, and a high flow 50 liters per minute through the nasal cannulae. Their primary outcome in the CPAP group, there was a reduction in favor of the CPAP. So this combined endpoint, less likely to require either invasive ventilation or death, but there was no difference in the primary outcome between the high flow nasal oxygen and the standard oxygen mask. It's a composite, so breaking it down into its individual components, you could see that the majority of that benefit was seen with the CPAP not requiring intubation, although I would point out that it still looks slightly in favor of reduction, for death, although the confidence intervals clearly cross 1. Whereas again, with the high flow nasal oxygen, there looks to be far less benefit. Was it safe? It appeared so. Obviously, not everybody tolerates face mask CPAP, so there was more intolerance of that compared to the other therapies, a little bit of hemodynamic instability, and maybe a small but increased rate of pneumomediastinums, although, as I said, absolute difference quite small. And I think we've become less concerned about the aerosol generating potential of these treatments. Investigators have shown when they've done environmental scans that actually there isn't so much virus floating around in the environments when you use either standard of care, CPAP or high flow nasal oxygen, and no more so than with the coughing, etc. So in summary, I would say what we've learned is that therapeutic dose heparin was useful for the less sick patients, but definitely wasn't for the critically ill patient. Aspirin didn't improve short-term outcomes, but it may have longer-term benefits. I'm not sure we know for sure, but it does look quite encouraging. We learned that CPAP does, I think, have a role. It's useful to try, at least, in the first place, and if your patient improves, great. And it doesn't seem to increase environmental contamination. And I think also we've learned that running randomized controlled trials are crucial to really understand what does and doesn't work and in which patients. Thank you very much.
Thank you. The paper is open for discussion, questions. But I always have this question, and I will keep asking the same question. How do you move this into the non-COVID area?
Which bit, the treatments or the trials? I mean, I suppose the answer is you bring the treatments in by doing the trials. I know, so REMAP CAP continues to tackle CAP in the UK. We've just got funding to tackle flu in hospitals. So we're now including patients on the ward. We're extending into children to study flu, antivirals for hospitalized patients with flu. We're testing steroids in flu patients. From this morning's Cape Cod trial, notice flu patients were excluded from that. So we don't know about steroids in flu. So we will answer that. There are other trials. Again, I know the UK environment better. There's an aspirin trial for over 50s with viral pneumonia underway now in the UK as well. We should be putting all our patients into trials, setting them up, putting them through, making it simple. How many results we've had in the last 3 years? We had a lot of patients. That obviously helps. But we put people in. At the beginning, when no one knew what was working, people were happy to randomize. I think it showed us we're often surprised by the results. And so I do think more of us clinical colleagues accept we should be randomizing when we don't know the answer.
Does this last statement trigger any comment or question?
Can I?
Yeah, here, over there.
So, in the COVID-19 for the thromboprophylaxis, do you recommend same dose of prophylactic dose of enoxaparin, like 0.5 milligram per kg daily dose? Or?
What do we do now? We are still, keeping true to message, we are still randomizing between the standard dose and the intermediate dose. We're obviously got a few patients coming in now, we're not seeing many. But in the ICU, we don't give the treatment dose, so in the ICU, we're using a prophylactic dose and we're comparing a standard dose versus an enhanced, which is double the normal dose.
Okay. So
I don't know the answer though. Therefore.
So antiretroviral. When the patient first day come to the ITU with the COVID-19, so how you recommend the remdesivir?
I will follow the previous speaker's advice. We don't use remdesivir by the time they come to the ICU. Some of our patients on the ward, if they're thought to be really early and high risk, do get remdesivir. So it sounds like we're not too different from the Netherlands.
Okay, the last
but we don't use it in ICU.
Last question is, so you mentioned that the HFNO and the CPAP, there is no difference. So high flow and the CPAP, there is no difference. High flow, there is no mortality benefit.
So there was no benefit of high flow compared to conventional oxygen, but there was benefit from CPAP compared to conventional oxygen. So we would, if a patient needs more than conventional, is desaturating, we would offer CPAP early. If you're going to ask me then the difficult bit, I don't know the answer, is when do you stop the CPAP and move to intubation? I think, but when they're not getting better.
We are usually used to use this HFNO, high flow, even there is no mortality benefit. The patient is having some difficulty in tolerating the mass and all. So at that time, how you recommend?
Yes, my medical advice would be use CPAP, but if a patient can't tolerate it, that's a different matter. And that's, again, that's where the art of medicine comes in. I would offer them CPAP, explain why I think this is the best treatment, but clearly I don't force it on people if they can't tolerate it.
Thank you very much. We have to move on. The next speaker is Dr. Alexander Vlaar. Anti-C5a antibody was the best. Another speaker from the Netherlands.
Thank you very much for the invitation and the kind introduction. Also for the title, which was provided by the organization. So I hope we can show that also in the presentation now. These are my conflicts of interest. So COVID-19, I think already mentioned, it's still part of the present and also will be in the future, although maybe at a different level than we were faced with in the pandemic. Mortality rates mainly also when arrived in the ICU, they remain high. Multiple organ failure due to uncontrolled inflammation. And still a significant part of the world is non-vaccinated. Immune-compromised patients may still develop severe COVID-19 and end up in the ICU. And what we do know already from the beginning, when it started in China, is that there is a key role of complement C5a activation in severe COVID-19. So if we look at C5, the place and the complement activation, we've got the classical, the lectin and the alternative pathway in which C5 in the end is released into C5a and C5b. C5b, very important in your MAC, which is of course important in your defense to other bacterial pathogens. And C5a on the left, very strong amplifier of inflammation and coagulation. What often is not realized that there is also an extrinsic pathway, so even when you block C5, you can still get C5a through the extrinsic pathway. The other issue, of course, if you have upstream blockage, you will also block your C5b, and in that way it results often in more side effects, more infections, which was also, I think, presented in this morning by Anana with their C5 intervention in COVID-19, which showed negative with also an increase of secondary infections, sepsis, and thrombosis. So why research then C5a inhibition in COVID-19? Well, already a monkey model of H7N9 induced viral pneumonia showed that it improved lung injury and reduced viral load. Also in MERS-CoV animal models, and we already had early evidence from China that C5a levels were very high and correlated with disease severity. So that led us already to design a phase 2 study when the pandemic started to hit Europe, in which we got already preliminary data that there is a signal into improved outcome. So our hypothesis is that SARS-CoV induces endothelial damage and activates the complement system. C5a again activates neutrophils, causing all the damage and the nets. C5a promotes also the coagulation through tissue factor release, which in the end also results in this syndrome we see of a huge inflammation and coagulopathy in these severe COVID-19 patients. What already was mentioned, the recommendations, of course, there is for the severe critically ill patients, but still in a way it is limited and mortality rates are high. So we have our dexamethasone, we have our prophylactic anticoagulant, we've got our tocilizumab, but there is not any other golden bullet and still high mortality rates. So Vilobelimab is an anti-C5a monoclonal. It binds with high affinity to this epitope. It blocks for 100% effect in the human blood. And again, very important to stress out, it leaves intact your membrane attack complex. And in that way, it might have a very nice profile regarding safety. So what I already mentioned, we performed already a phase 2 at the beginning of the pandemic. We published in Lancet Rheumatology, and based on the phase 2 results, we designed the phase 3 results with a primary endpoint of 28-day all-cause mortality. What we noticed was that the effect was most in the more severe critically ill patients, so that's why we only included patients on invasive mechanical ventilations within 48 hours. It was a global study with a worldwide enrollment in Western Europe, Russia, US, Mexico, Brazil, Peru, South Africa, and where we compared Vilobelimab plus standard of care or placebo plus standard of care, double blind. Several secondary endpoints which I will go through. So these are the baseline characteristics, very nice balance, also regarding enrollment. On the bottom you see that the standard of care at that time was given to almost all of the patients, which I think makes it also very extrapolatable into the clinical setting. On the right hand in the table below, you see the baseline differences on severity. The only thing what is a bit standing out is the 8-point ordinal scale, that in the placebo, it seems there were a bit more higher scored ordinal scale 7 compared to the intervention, but I will get back to that later on. So these are the PK/PD data in which you see that the Vilobelimab is really available in the patients on the left, and what you do see on the right is that there is a really good control of your C5a levels in those COVID-19 patients in the blue boxes and the red-orange boxes to control. So this is the primary endpoint in which we had a 22.7 relative reduction on day 60 and a 23.9 relative reduction on the day 28. So one additional life was saved for every 10 Vilobelimab treated patients at day 28, and one additional life saved for every 9 Vilobelimab treated patients at day 60. The effect is huge. However, we had Cox regression center stratified analysis, which was asked also in discussion with the FDA to update instead of non-correction for that. This results in just not hitting the p-value. And it was very interesting and also for us to see what was causing this not hitting the p-value. Here on the top you see the stratified per site, which did not result in a p-value, a p0.094, but a huge effect. So we dove into it, and what turned out, if you stratify by site in this Cox regression, you will not take into account sites with no events, so no deaths, or just single enrollment sites. It's a mathematic issue in this model. And because it was blinded, we did not know yet where no events were and which treatment arm patients were in. So we could not foresee this in a way. We had in the primary protocol unstratified, but at the last moment, what I was mentioning already in discussion with the FDA, they preferred that. So we did all this predefined already analysis, an unstratified, stratified by region, stratified by country, random effect, stratified by pool sites also with small enrolling sites. And there you see that this is really solving the problem, and then the effect size, which is there, is also becoming significant. So pooling the smaller site for stratification adjustment with Cox regression analysis leads to this consistent lowering of the p-value in the model. So this hazard ratio and confidence interval shows a consistently strong benefit of vilobelimab. This is the same for the 60-day, we showed it as well. So in the Western Europe, when we look there specifically, we have a 43% relative reduction in 28-day mortality. This was predefined, which was also strongly significant. So one additional life was saved for every 6 patients at day 28, and for every 7 patients at day 60 who were treated with vilobelimab compared to placebo. Also, the groups pre-specified for baseline ordinal scale. What I was mentioning in the beginning, there's this imbalance maybe at the baseline, but if we look at specific this patient group, the more severe, the benefit is most in this more severe patient group. The same for severe AADS or patients with already renal failure. Those patients are benefiting the most, which of course is very important for us in an ICU setting, that especially those most severe critically ill patients are benefiting most of this anti-C5a intervention. Also, renal outcomes with vilobelimab show a signal to benefit, so less acute kidney failure or less need for renal replacement therapy. And can we understand it mechanistically? Well, we already have the C5a role in observational studies, but also here we see stratification of neutrophil lymphocyte ratios in critically ill COVID-19 patients, that where this ratio is highest, there is the most effect. This is also known to be associated with the most severe COVID-19 patients. So this, I think, is confirming this as well. We have also a biobank. We're doing analysis now also to clarify the pathways involved and the mechanisms in place, how C5a is doing this interaction. And I think also of interest for getting this drug also in sepsis or other viral ARDS settings. So the safety profile, what I already was mentioning, what we know, if we block higher up in the complement, we have this danger of secondary infections. There was no prophylaxis given in this trial, which is known with other complement inhibition. But what you see here, if you block downstream, really only C5a, your MEC is still in place, and the side effects are none. They are similar with the placebo group, the number of infections. There might be some trend, it seems like it's a bit higher, but that's the problem, that patients are surviving, and if patients survive, they have a higher chance of having an infection. So if you correct that for patients per 100 patient days, there you see that actually even vilobelimab has less adverse events. So summary, the primary endpoint of 28-day all-cause mortality has a clinical meaningful benefit in vilobelimab arm, but missed its statistical significance using pre-specified site-stratified analysis method. If we look at the pre-specified and post-hoc analysis, non-site stratified, which was also in our primary protocol, but after discussion with the FDA updated, suggests statistical significant and robust reduction in mortality at day 28 and day 60 in vilobelimab-treated patients compared to placebo. A significant treatment benefit in predefined analysis of Western European patient population with a 43% relative reduction in 28-day all-cause mortality in this critically ICU mechanical ventilated patient population. And also a significant treatment benefit in all 3 predefined subgroup analysis of patients with higher disease severity at baseline, such as the ARDS and the kidney failure. And a favorable safety profile for vilobelimab confirmed in its critical ill patient population. And the company is now also discussing with the regulatory authorities for approval. Thank you very much.
Thank you. The paper is open for discussion. Question, comments? Again, now that COVID is over, would you indicate the use of this compound for non-COVID ARDS?
So that's a very interesting question. First, we need approval because it's a non-registered drug at this moment. So when it hits approval, I think this would be a very perfect drug to start studying in any form of ARDS, but also sepsis. A first phase 2 sepsis study has also been done already. Because of this very beneficial safety profile, but also this very strong action in the mechanism in place in viral pneumonia, where we already have the evidence in animal models and also in the previous MERS and other flu ARDS. We have already the evidence, but we need to get it now also in the clinical setting. But yes, I would definitely go for it.
Okay, questions, comments? If no, thank you very much. And we move on to the next speaker, who is inhaled heparin as an option, Dr. Frank van Haren from Australia. A long flight to get here. Thank you very much.
Marco, thanks very much. Ladies and gentlemen, thanks for staying. Don't you have something better to do than listening to this marathon session of COVID-19? I have no relevant disclosures, and Marco, especially for you, you were wondering why is this session so long. That's because if you look this morning in PubMed, there's already 350,000 publications on COVID-19. So it takes a couple of hours to get through all this research, right? Almost 3,500 clinical trials, and in the pipeline, there's another 9,000 studies on clinicaltrials.gov, so there's more to come. Reminding everyone, in December 19, when the first cases were identified, within a month we already knew how the virus enters the cell, and this is relevant for the rest of my talk. And this sort of shows how the community came together and did all the research in COVID-19. We've heard a lot about the COVID-19 complex pathophysiology, we've heard about the inflammation, the coagulopathy. We didn't talk this afternoon about the compliance and this sort of weird situation where you have patients who are deeply hypoxic but still have relatively normal compliance. And we asked ourselves, is this really a new thing in COVID-19, or did we see this before? So we went back to our LungSafe study that we published a couple of years before that sort of explains ARDS and how we treat ARDS in the wide world. And we went back to the database and looked at compliance and hypoxia pre-COVID. And essentially what we found was that in patients where we had compliance data, a normal compliance with deep hypoxia was definitely not something new. So pre-COVID, in non-COVID ARDS, 1 in 4 patients had a compliance over 40 and 1 in 8 patients had a compliance over 50. So this is not a new thing. And in fact, in LungSafe pre-COVID, we also found that there was no real relationship between compliance and hypoxia. So this idea that all your ARDS patients need to have stiff lungs with low compliance is not true. Even pre-COVID, that wasn't true, and certainly in COVID, it's not true. That doesn't mean that COVID is not an entirely new disease, and I think the pathophysiology is quite different. And I'll just talk you through this slide quickly and then show you how this may be relevant to inhaled heparin. So we know that the virus needs to enter the cell by binding to the ACE2 receptor, and by doing so, it immediately causes lung injury by hijacking the ACE, and you get vasoconstriction and immediate lung injury. Of course, we talked about coagulopathy. We mainly heard this in the context of getting clots, but the coagulopathy is also relevant in developing ARDS because fibrin actually contributes to the hyaline membranes that you see in ARDS, as I will show later in our ARDS study of inhaled heparin. Thrombosis, we've heard this before numerous times, is far more common in COVID ARDS than in non-COVID ARDS, and hence the REMAP-CAP studies on heparin and aspirin. The inflammatory cascade is basically through macrophages that are activated that then give this massive pro-inflammation. But what a lot of people perhaps don't realize is that the neutrophils end up being or forming neutrophil extracellular traps, and they are very toxic for the lungs as well. So there's additional lung injury from these DNA nets. And again, that's relevant because heparin prevents formation of these DNA nets. So when you look at this sort of simplified pathophysiology, then the simplified answer could be antivirals, anti-inflammatory drugs, or anticoagulants. The reason that we wanted to look at heparin is that heparin has all three of these characteristics in COVID and also in other viruses and bacterial infections. So when we look at heparin, heparin in fact stops the COVID virus from entering the cell. And I'll explain how that works. It binds to the spike protein, but let's take one step back. How is heparin available in our body? Normally, most of it is attached to cell membranes, and it's heparin sulfate that's an important mediator. It's almost like a mop, and it sort of mops together molecules that then it will present to other receptors to activate these receptors. And exactly that happens with COVID and lots of other viruses. So this heparin sulfate basically mops up the virus, presents it to ACE2, and then it binds to ACE2 and enters the cell. So when you give heparin as a decoy, it can't bind anymore to heparin sulfate, and this is how it stops the virus from entering the cell. It's not just COVID, it's a lot of other pathogens, bacterial and viral pathogens who use the same mechanism and therefore could potentially be susceptible to the same treatment. The actual antiviral effect of heparin has been shown in cell cultures. This is from our UK collaborators who showed that it's very effective and in fact much more effective than low molecular weight heparin in its antiviral activity. Since this study 2 years ago, that's been shown a number of times by other groups, and more recently by this group that looked at animal studies looking at inhaled heparin, but also inhaled heparin polysaccharides as a decoy to prevent the virus from entering the lung. And they showed that there is less lung infection with virus, with COVID, when you use heparin. So heparin stops the virus from entering the lung, which is probably relevant. And then it has the usual anticoagulation activation. I won't talk too much about heparin, the anti-inflammatory effects of heparin. They've been well studied, and they are the reason why heparin in inhaled form is sometimes used in severe COPD. Heparin also reduces the nets. So, is there any evidence then that heparin, inhaled heparin could work? Well, pre-COVID, there was already quite a bit of evidence in lung injury, so non-COVID lung injury. So this is preclinical evidence, laboratory data, animal studies that sort of all pointed in the same direction. If you use inhaled nebulized heparin in lung injury models, it reduces the coagulation problems in the lung, it reduces the inflammation, and it improves some of the oxygenation. In clinical studies, again, pre-COVID, and these are lung injury studies in burns and other models, not models, but in patients. Again, all these studies sort of pointed in the same direction, that when you nebulize heparin, you reduce some of the coagulation cascades, and in these studies it actually improved some of the lung injury scores and reduced mechanical ventilation. This is a recent paper to show that it might work in COPD, which is not very relevant for this talk. So again, pre-COVID, we did a study in ARDS patients who had ARDS or were at risk for ARDS, published in the Lancet Respiratory Medicine journal 2 years ago. And in this study, where patients were randomized between inhaled heparin or inhaled saline, the lung injury improved much quicker and much more significantly in the heparin group compared to the placebo group. Patients who were at risk of developing ARDS, in the heparin group, there were less patients who developed ARDS compared to the saline group. So these were some of the secondary outcomes. The primary outcome was actually physical function after 60 days, which wasn't different between the two groups when we compared it as we planned to do with the mean score. But you can see that the shape of these two graphs is a bit different. So we did a post hoc analysis, and for what it's worth, it is a post hoc analysis, but it did show that the heparin group had less patients in the worst outcome. So with heparin, there were less patients who had a very, very poor physical function at day 60 compared to placebo. So there were some signals that heparin could be useful in these patients with ARDS or at risk of ARDS. So is there any data then on COVID-19 and inhaled nebulized heparin? We offered it to REMAP-CAP, but unfortunately we were just too late because they just decided on the actual heparin arms. So we went our own way, and it's been a bit difficult to get enough patients. But this was a case series from 3 hospitals, 2 in the US and 1 in Argentina, so an uncontrolled case series, but these patients received inhaled heparin. After these doctors read our publication, they thought, oh, it's a pretty good idea. We don't know what to do anymore. Let's give them some nebulized heparin. And we just described in this case series what happened to these patients. First of all, it appears to be safe. So there was no clinically relevant increase in APTT. So the heparin that's inhaled is not actually systemically absorbed and doesn't have a systemic effect on APTT that's relevant. Almost half of these patients already received therapeutic heparin or therapeutic clexane or another low molecular weight heparin, and adding nebulized heparin did not increase complications, and there were no bleeding complications, importantly. So it appeared to be safe in these 100 patients. And some exploratory outcomes, again, this is, there's no control arm, but time 0 is when the heparin was started, and you can see this is a measure of oxygenation, the saturation over FiO2 ratio, which is like a poor man's PF ratio, that started improving after heparin was started, both in intubated and non-intubated patients. And similarly, the FiO2, that was creeping up in these patients. The patients were getting worse and worse. Heparin was started, and after that, the FiO2 started coming down. There's no control group, so we don't know if this is real or if this is just by chance, but it certainly is sort of encouraging signal. The first pilot RCT is about to be published, a study in Brazil that was funded from the UK. The study was stopped early because recruitment basically stopped. They didn't have any patients anymore for 3 months, so they only recruited 76 patients. Safety was fine again. There was no APTT difference between the patients who were randomized to heparin and the patients who received standard of care. And there was perhaps a signal, but we have to be very careful with this, that mortality was lower in the heparin group in the modified intention to treat arm. And I think that's just a hypothesis, that is not in the intention to treat arm. That was not significant, but obviously this is a small pilot RCT. Other outcomes that I haven't put on the slide improved as well. So the WHO ordinal score improved in patients who received heparin versus standard care. So where are we at the moment? We are running a meta trial again. It's a poor man's remap-cap. A meta-trial is sort of a new way of doing research where you prospectively combine studies that have not been set up to be combined originally. So, you know, they started doing a study in Egypt on this topic, and they started doing a study in Ireland on this topic, and we reached out and we said, can we combine all the data even before you have finished the study? You may have seen a meta-trial of proning. I think that's the most famous meta-trial that's been published that was done exactly this way. And it provides us with an answer a bit quicker. So we're currently at close to 600 patients. We have a management committee meeting soon. And I think because recruitment has dried up, I think we probably have to stop and just analyze and publish. We're also waiting for data from Ireland with the new rules around data sharing agreements in Europe. It's very difficult to get the data from Ireland, but hopefully we'll get that soon. So this was the protocol and analysis plan. We are cleaning the data at the moment and we'll be publishing soon. That was a study in hospitalized patients that are not yet intubated. We run a separate similar meta-trial in patients who are already intubated and ventilated. And again, it's inhaled heparin versus standard care. This study, now that not many patients get intubated anymore, is also not recruiting. So we are looking at doing a similar thing, stopping recruitment and analyzing the data. So in summary, we think there is a biological rationale. Well, certainly there was enough rationale to test nebulized heparin as a treatment because of the antiviral effects that have now been well established, the known anticoagulant effects, the anti-inflammatory effects, and the mucolytic effects. We think there is perhaps some emerging clinical rationale, but we have to wait for the results, obviously, of the meta-trial. What I didn't mention, why did we start with heparin in the first place? All the treatments that you've seen so far on the slides are very, very expensive and are probably not easily available in low and middle income countries. Heparin is available everywhere in the world. It's in every hospital in the world has heparin. So if heparin works for these types of infections, so this is now COVID, but it might well work for influenza or the next pandemic, then we have something that's in the fridge everywhere in the world that we could use. So we thought that's quite a good reason to investigate this further. That's it. If you have any questions, just shoot me an email, and thanks very much.
Thank you, Frank. Paper is open for questions, discussion. Now, it's, again, you said heparin is in the fridge, we can use it the next pandemic. Why not use it the next case of ARDS? First. Second, is a technical aspect. I mean, you are running a meta trial, and the way how you deliver a drug with inhalation therapy is quite different depending on the ventilator, the equipment. How do you guarantee the quality of the signal-to-noise ratio of your trial?
Yeah, that's a very good question, Marco, of course. If I can start with the second question, that is a problem. So this meta trial is going to be relatively messy because there are different delivery systems used in the different studies and even different doses. But we might be able to, because of that, we might be able to see a dose-effect relationship as well. I guess what we're after is just a general effect of direction of effect and magnitude of effect, and we use Bayesian analyses as well to see if there's a probability of an effect on intubation or mortality or other outcomes. Then back to the first question, should we use it for ARDS now? I think you know, we only have one phase 3 trial now with nebulized heparin and ARDS. I would like to see that done again or replicated. It was a relatively well done study, but only 500-600 patients. The outcomes were encouraging, but I think we need some more work. In terms of the future, once we establish an easy way to give nebulized heparin, and once we establish that it works as an antiviral, I think, if there is a next pandemic with something that's quite similar that also uses the heparin sulfate to then enter the cell, we could be ready. Of course, he ran away quickly, but we might be able to put it in remap cap for the next one.
Antonio.
Thank you very much for your presentation, Frank. I have two quick questions. The first question is combination therapy. Do you have any information on to combine heparin or anticoagulants with other treatment? And do you think that the duration of the treatment, do you think that is an important factor to maintain 10 days or why not 5 days or no 2 weeks?
Yeah. Thank you. Very good questions. In terms of combination therapy, all we can say so far is that adding inhaled heparin to any systemic heparin, either prophylactic or therapeutic, is safe. So we have not seen any additional bleeding, complications, or pulmonary bleeding or anything else. We think that the doses that we get in the lung with inhalation that's much, much higher than you will ever get with therapeutic anticoagulation. So we think that is the key to why inhaled nebulized heparin might work much better than giving it IV. So there's no safety concerns whether there is additional benefit, perhaps because of the high concentration in the lungs. The second question was about
duration.
About, sorry?
The duration of the treatment.
Duration, yes. So the short answer is we don't know. But certainly the pilot study in Brazil showed that if you have a very short duration and then you die, then of course the heparin didn't have any effect or couldn't have any effect. So there's this modified intention to treat analysis, which is a little bit tricky, I find. Excluded patients who didn't get the treatment, who didn't get at least 4 doses of heparin. So after 4 doses of heparin, there was a separation of the two groups in terms of outcome. But if patients had mortality or intubation pretty much before they could get any heparin in that study, then we couldn't show any effect. How long we have to continue, we don't know. We have the different protocols, as you know, the different protocols in the meta trial have different durations. It's up to 21 days in some of the protocols, but most studies that contribute to the meta trial stop when the patient has been extubated or discharged from ICU or discharged from hospital. Thanks.
Thank you very much. It's time to move on. The next speaker is Dr. Michel Chu from Sweden. COVID-19, what we learned, stress, anxiety, and burnout. Michel.
Thank you very much, Mr. Chairman. And thank you to all of you who are staying on. So I've been asked to talk about stress, anxiety, and burnout, and I know that every single one of you sitting here know about this, having been exposed to the environment of intensive care as well as COVID-19. So just to start with a few definitions, because stress, anxiety, and burnout are quite often used interchangeably. So let me just say that there are very different definitions. The WHO defines stress as a state of worry or mental tension that is actually caused by a difficult situation. So it's something that's already happened, causing mental worry. It is a natural human response, and it can be adaptive because it causes the individual to act upon that stressor. But it can also be maladaptive, and when it is maladaptive, such as when stress occurs at work under chronic over a long period of time, this is called job strain, and there are special definitions for this. It may be linked with anxiety and depression, but it is also linked with physiological risk, so an increased risk of cardiovascular diseases as well as poor cardiovascular outcomes. And there are very well-validated instruments for measurement of stress. Now, anxiety, on the other hand, refers to the anticipation of a future event. So it's an event that hasn't actually occurred, but then you're worried about it. And it becomes a disorder when those feelings are strong enough to interfere with daily life. And there are also validated instruments for measuring anxiety that are context and language specific. So burnout is often lumped together with stress and anxiety, and they are very interrelated. But burnout is actually a syndrome. It's a syndrome that is best conceptualized as resulting from a chronic workplace stress that has not been successfully managed. So the implication there is that if you can manage this chronic workplace stress, you can reduce the incidence of burnout. And there are several validated instruments for measuring burnout. The most well-known of these is the MASH burnout inventory that measures burnout in 3 different domains. I'll come back to that later. So this paper in the Lancet Respiratory Medicine really highlighted burnout in intensive care healthcare workers under the COVID-19 pandemic. And I'm sure all of you will have felt this. And it is also perhaps linked to the staff shortages that we're seeing today. I'm sure that Sweden is not alone in having nursing shortages, for example. However, burnout is not a COVID phenomenon. Pre-COVID studies have shown that burnout is highly prevalent amongst all categories of workers within the ICU. We know that there are some risk factors, for example, gender, although that is debatable because after correction for, say, age and other workplace factors, it may not be an issue. We do know, however, that the nursing profession is at particular risk. There are also other workplace issues, workplace factors such as conflict and the lack of non-clinical duties or activities that may be associated with an increased risk. Interestingly, there's a huge variability in the definition of burnout, despite the fact that the MASH inventory is a well-validated and well-used instrument. The cutoffs that are used are considerably different from study to study. And again, I want to stress that burnout is not exclusively a COVID-19 phenomenon. So this is one of many studies that have been published regarding burnout during the COVID the early phases of the COVID period. This was a large study conducted by the Emory Healthcare Service, and it shows that women are disproportionately affected. So women, 71% of women in this healthcare service suffered from burnout compared to 60% of men. We also know that nurses were more affected than other professions. 58% of nurses suffered from burnout before the pandemic, so this is a very, very high prevalence, compared to 72%, so increased remarkably during COVID. Physicians had the lowest rate of burnout, 51% pre-pandemic, to 58% post-pandemic. So even the group of workers with lowest rates of burnout had very high prevalence. So how does stress relate to burnout? Well, I guess stress can be considered from via different models, but one model is this effort-reward imbalance model. So that model states that the effort spent at work outweighs the rewards received in return. And in terms of rewards, it's not just a matter of remuneration in terms of wage and salary. There are also non-material remunerations such as flexibility, employer satisfaction, and employee satisfaction. We also know that acute events superimposed on a chronic long-term stress is deleterious for health. What we don't know, or what we know less about, is whether or not this can be modified by anxiety, because anxiety is a potentially treatable condition. So at our health service, which is the 4th largest health service in Sweden, we asked ourselves, how does chronic stress contribute to burnout in the acute COVID pandemic period? And is there a difference between professional categories? Knowing, of course, that Sweden is a reasonably equal country, it has good legislation to protect working parents, etc. And we also asked if there is a difference between stress levels amongst healthcare workers before and after the pandemic. So we did a cross-sectional study. At that time, we had a workforce of about 700 ICU workers across all categories, so the response rate was not great, but this is what happens with surveys. And we identified, or we measured anxiety and depression, self-reported stress and burnout using validated context-specific, so transferred into the Swedish situation questionnaires. And we supplemented it with the areas of work-life survey. So this is a survey that measures several aspects of the workplace that may explain why people are burnt out. Now, in order to measure chronic stress, we developed, or our university developed, a method for measuring cortisol in hair. So cortisol is retained in hair, and every centimeter of hair corresponds to about 1 month of stress. So for those of you who don't have any hair, this is not the method of choice. So obviously this was a disadvantage with a lot of our male workers, and you will see in a few. Actually, you can see it here. Most of our workforce were females, but we did lose quite a lot of males due to the lack of hair. So 274. The vast majority were females, a small proportion of physicians, the vast majority were nurses and nursing assistants, but also dribbles of other professions. Now, we also sampled non-regular ICU staff. So these were staff, mainly from anesthesia, that were seconded to work into the ICU during the height of the pandemic. So I know this is a messy slide, but all I want you to do is just to get the gist of it. So this is anxiety, this is depression, and this is the perceived stress scale. So this is self-reported stress. So anything above the line is anxious, anything above the blue line here is depressed, and anything above the blue line in the last graph is high levels of perceived stress. And you will see, I'm so sorry that this is in Swedish, I didn't notice that before. So what you will see here is that does it work? Okay, it doesn't work. So basically all I wanted to say was, in terms of emotional exhaustion, so the first domain of the burnout inventory, there was no difference between men and women, there was no difference in terms of work category, and there was no difference between the regular ICU staff and the staff that was seconded. And similarly, our workers were thankfully not depressed. However, in terms of measurement of perceived stress, so this is self-reported stress, we rated high. So the blue line is the nominal data from a Swedish background population. So high levels of perceived stress. Now, we measured hair cortisol as a measure of physiological chronic stress, and what we saw was that the levels here were higher than a background population. So about 30 to 40 picograms per milliliter, and the males had higher levels than females. So the SCARPIS, that is a study that is ongoing in Sweden. It's a huge population-based study. We're currently recruiting about 30,000 patients, and I'm sorry, they're not patients, they're just normal healthy people in the population. And about 700 of those, of that sample were healthcare workers, although not exclusively within intensive care. And what we saw was that hair cortisol levels were indeed higher amongst ICU staff that worked during the pandemic. Interestingly, however, there was no correlation between the physiological chronic stress levels that we measured in hair and perceived stress. So just to conclude, I just wanted to again reinforce the fact that although COVID-19 was a stressor and it did increase levels of burnout amongst ICU staff, it is not a phenomenon completely just tied to COVID. This has been pre-existing, and the literature is replete with how ICU workers have been suffering for a long time from anxiety, stress, as well as burnout. We know that there is an increasing prevalence of burnout, and this perhaps explains the staff shortages that we see today. We know that gender and profession seem to be risk factors, although there are not enough large studies that have adjusted for enough confounders, and a Swedish study showed no relationship between chronic stress, perceived stress, anxiety and depression, and burnout. Thank you very much.
Thank you. The paper is open for questions or discussions. Now you mentioned, no, it doesn't need anymore. Now you mentioned a gender-related risk factor. Would you comment a little bit more on that, specifically related to COVID, and as you correctly said, in general terms, because this is a phenomenon that takes place every day in the ICU, COVID or non-COVID?
Yeah, correct. So there are a multitude of smaller observational studies that have confirmed, or rather that show the association between gender and burnout, regardless of how you measure burnout. And those studies show that female workers, regardless of profession, whether they're doctors or nurses' aides or whatever profession, seem to be at an increased risk of burnout over the long term. However, those studies have not adjusted for other factors such as age, experience, whether or not you're seconded to work into ICU, as well as a multitude of other confounders. Bearing in mind, of course, that a lot of studies have a predominance of females. So many studies have 90% of females, so it's difficult to make those sorts of adjustments when you know that the groups are not evenly weighted.
Okay, if no more questions, we move on. Thank you very much.
Thank you.
Our next speaker is Dr. Janet Diaz from Geneva, Living Guidelines for Clinical Management of COVID-19, what we have learned.
Good afternoon, everyone, and thank you. I just want to thank the organizers and everyone for inviting me to present here, and thank you, Marco, for the introduction. And it's late, so I will try to keep this exciting. So I actually, my conflict is that I work for the WHO in Geneva, and I lead their clinical management and operations unit in the health emergencies program. And as part of that, I have been responsible for the living guidelines for clinical care and therapeutics for COVID-19. So I'm just going to go back. Everyone remembers these times, but in times of uncertainty, what should we do? And that was the questions we were being asked, everyone, during the beginning of the pandemic. And still we're asking, what can we do better? Apply indirect evidence, conduct clinical trials to find answers quickly, synthesize, interpret evidence using standard methods, do no harm, risk and benefits at the patient bedside. So I'm going to try to cover some of these things in this talk and what led us to do the living guideline. It is extremely important to develop guidelines that are transparent and trustworthy. And WHO has, our handbook for guideline development that really describes in detail the norms and standards of how we should be developing recommendations. And it describes well the evidence to decision framework and how we build consensus on benefits and harms, values and preferences, equity, feasibility, cost, and access. But in order to do this during the pandemic, we had to accelerate this type of work, which traditionally had taken WHO departments about 1 to 2 to up to 3 years to write one guideline. And we didn't have that kind of time. So we quickly set up a group of international experts, 30 to 40, probably more than that, because we've been going for a couple of years now, and we've convened many, many different groups. They represent all WHO regions, different medical specialties, including ethicists and patients. All the guideline development group panel members are unconflicted, no financial or intellectual, and participate in standing virtual meetings, which used to be once a week during the most busy times of the pandemic. As a governance group, we have a steering committee, of which I lead, and my colleagues from different departments within WHO and at the regional offices. We have systematic review teams that we work on that do the evidence appraisals, an external review group, and within the guideline development group, we have a methodology chair and a method support team and a clinical chair. There was lots of requests to make our guidelines faster. at the beginning of the pandemic. At the beginning, there was a lot of pressure to say, what should we do? What drugs should we use? And everyone was using lots of different types of drugs. Luckily, at the same time, there was a lot of good clinical trials that began early in the pandemic, specifically those large platform trials that were able to generate evidence quickly to allow us to make recommendations. So we went from a complicated time of clinical uncertainty, and we tried to commit to an average time of 8 to 12 weeks to publish a recommendation if some evidence had emerged. So in order to do that, we had a pretty systematic approach that was developed over time. We had good coordination with platform trialists, meaning we knew what they were studying. We had an idea of how they were enrolling and when their studies would be completed. We were monitoring RCT evidence and publications and preprints, meeting with trialists as well about certain high priority interventions that would benefit from a more rapid evidence synthesis, conducting meta-analysis, and then recommendations being developed by our guideline development group, and then dissemination. Just to emphasize, and at the end I will show my acknowledgements, and there are probably 2 or 3 slides. There are so many people that contributed to this effort, and it's hard to, I'm just mostly grateful that everyone agreed to work with us, so clinicians, researchers, methodologists, systematic reviewers, journal editors, patients and families, of course, that enrolled in those trials. So the trigger for writing a new recommendation for us, we had to be transparent, so we thought if the evidence, if any of the following occurred, there was likelihood that this evidence was going to change a practice. There was sufficient RCT data, so we decided just to focus on the clinical trial, randomized clinical trial data, because we didn't want to go into the observational data, and there were so many trials being done, and that would inform the highest quality evidence synthesis. So specifically that these studies had enough endpoints for us to do the analysis, and that it was relevant to a global audience. We had a few innovative approaches, and again here, just to acknowledge Reid Siamenyunuk and his LNMA team from McMaster University that did this phenomenal job on a living network meta-analysis that you can find on the BMJ. So their team did a comprehensive daily monitoring of all emerging RCTs. They had a multidisciplinary group of information specialists, clinicians, researchers, and methodologists that were looking at this, and they were using, and we all decided that they would incorporate preprint data to promote rapid data sharing. This then informed the WHO Steering Committee of any practice-changing evidence or increasing international interest, and WHO then triggered the writing of the recommendations. And on the right, you can just see the schematic of their living network meta-analysis, and really easy to follow what drugs were looking beneficial, which ones weren't, and which ones remained uncertain. Another approach that we took was the prospective meta-analysis, and we developed a nice working group, WHO REACT, Rapid Evidence Appraisal of COVID Therapeutics. And here I want to give a special thanks to Manu Shankar, Jonathan Stern, John Marshall, Srinivas Murthy, Claire Vale, and Peter Gundolfin, who have been the core group in helping us put through these prospective meta-analysis. So what was innovative about this? This actually was a little bit separate approach. We decided to go to the trialists to plan a prospective meta-analysis with trialists before their studies were completed. So instead of doing the traditional route of waiting for publication and then doing the meta-analysis by a separate group, we thought we could do it with them. So before the studies were completed, we met with this independent group of methodologists, data scientists, biostatisticians, and clinical researchers that I just acknowledged. And together with the trialists, we developed a prospective meta-analysis protocol. We found them, identified them through searches, systematic searches of trial registries. Then we developed with them the protocols, including subgroups, outcomes, and analytical plans. This protocol was then published before their results, before they completed their trials, to ensure that it was a transparent and trustworthy process. And then with them, we monitored their trial recruitment and timelines. We knew when their trial was going to be completed, so we knew when to plan data analysis. So what was really great with some of these, with this approach, was that we had, trust and we had confidentiality. So once they were clear that their data sets were closed and cleaned and ready, they were able to share with us, WHO, in order to do the meta-analysis before they went into the public space. That allowed us to rapidly develop evidence summary tables, convene the GDG, and go forth with the graded recommendation process. And then coordinated publications tended to happen kind of at the same time, the meta-analysis, the WHO guidelines, and in some cases, those trials, the primary trials themselves. There were two important ones at the beginning of the pandemic, which I do want to highlight just for timing reasons. And the first was the association between administration of corticosteroids and mortality amongst critically ill patients with COVID-19. And just to remind everyone, on the 17th of July, 2020, Recovery published its the largest trial that was done on corticosteroids. And by 2nd of September 2020, we had our prospective meta-analysis published. So that was pretty good timing, I think, with the results of REMAP-CAP and CODEX trial. So our meta-analysis was informed by a total of 7 trials, 1,700 patients that were conducted in trials between the period of 26 February to 6th of July. And that same day, the living guideline for COVID-19 therapeutics, the first version, was published. And that was, a really important game changer, obviously, seeing that corticosteroids reduced mortality in patients with severe critical COVID-19. The other important one that we were able to process quickly was the associations between IL-6 receptor blockers and mortality among hospitalized patients with COVID-19. Again, just to show you the timelines, REMAP-CAP published its study in the 22nd of April, 2021. Recovery then subsequently publishes its large trial on the 1st of May. And by the 6th of July, we have our PMA publishing, which included 27 trials, over 10,000 patients, and the same day, our living guideline updated. Going on from there, when we do these meta-analysis, then we have to present the evidence summaries to the independent panel. And so it is really important with the independent panel now, so now I'm talking not with the systematic review teams, with the independent guideline development group panel, that we need to talk with them before they see these evidence summaries. So it's a separate group. And pre-specify things into that analytical plan that then the systematic review team uses. Subgroups, which subgroups do they want to look at for the interventions? What are the prioritized patient important outcomes that they want to see when they see those tables? What are the baseline risk estimates that we're going to use to derive the absolute risk reduction? What are the values and preferences? And then we relook at the grade of all the studies. This is then packaged, and I'm going to show you an example of the easy-to-read evidence summaries that are published with our guidelines. And here, just to show you on the right, I just circled, that's the patient important outcome, it's mortality. This is the summary evidence table for IL-6 receptor blockers compared to standard of care. And the next row, then you can see the odds ratios and the number of trials and patients that derived that odds ratio. And in the middle, you can see the absolute effect estimates, so the baseline risk of death in the standard of care, and then the baseline risk of death in the IL-6 receptor blocker. Next, you can see the certainty of evidence as it was graded to be high, and then a plain language summary that simply says IL-6 receptor blockers reduces mortality. So these grade tables are then shown to the GDG in a very structured way. The consensus meeting is led by our clinical and methods chair, and draft recommendations are made. At that point, we would usually just go through 1 or 2 drugs at a meeting, and then we would draft the guideline, send it to review by the guideline review group at WHO, an external review group, and then it's approved for publication. Just going into a little bit more details about the use of values and preferences. So in these consensus meetings, it's actually important to understand what are the values and preferences of your patients. And so this is what we use in our guideline, and you can see it on the web, that most patients, and this is from the beginning of the pandemic, that most patients would be reluctant to use a medication for which the evidence left high uncertainty regarding effects on outcomes they consider important. This was particularly so when evidence-suggested treatment effects, if they do exist, are small, and the possibility of important harm remains. In an alternative situation with larger benefits and less uncertainty regarding both benefits and harms, more patients would be inclined to choose the intervention. So these types of values and preference statements help us, have these difficult discussions with the GDG to decide on making the evidence to decision, also looking at cost, equity, feasibility, in addition to the harms and benefits from the evidence summaries. And finally, you end up with a strengthened direction of a recommendation developed through a consensus process. So going on from there, we make the recommendations, we have a meeting, but then we have to disseminate it. And here we also, I think, worked on innovative techniques. We worked collaboratively with the BMJ and did their rapid recommendation series. And so all our therapeutics guidelines were published there. And thanks to their good infographic services, we have an infographic on the left that shows COVID patients of the different severity groups. And then simply you can follow this, look at the strong recommendations. And currently, this is the most recent one we have for non-severe patients at high risk, strong recommendations in favor for nirmatrelvir or ritonavir, and conditional recommendations in favor for molnupiravir and remdesivir. And then in patients with severe COVID-19, we have corticosteroids, IL-6 receptor blockers, and baricitinib that can be used in a combined way. And at the bottom, you see remdesivir, which was just updated for that patient population that's severe, meaning on oxygen but not intubated or on invasive ventilation. And on the right, what you can see, and this is all an interactive infographic. You can touch on the drug itself, and then see simplified evidence summary tables, how to use the drug, what is the dose of the drug, and what's the strength and the direction of the recommendation. And here, just to guide you, we do use grade, we do use strong and conditional. Some people use weak and instead of conditional, but we kind of try to keep to those standards in how we explain our recommendations. Something else that was innovative, we worked with collaborators, Magic Ecosystem. They have a website, an interactive platform for writing guidelines, and as well interactive platform for looking at evidence summaries. So for those of you that like to look at these details, this is just an example as well from the IL-6 receptor blockade. And again, just looking at the prioritized outcomes, the differences between standard of care and the drug, looking at the absolute risk differences here and the certainty of evidence. And this can be shown in many different ways, but just trying to bring the data alive to people to access and process. Here's another tool in that magic app. Here is which drug should I use? An example of making choices between oral antivirals for COVID-19. Of course, we have a strong recommendation from one of them, so that would be the preferential one. But if you wanted to look and compare the absolute risk reductions among 1,000 people, you could look at the patient-important outcomes on the left, the standard of care estimates, and then the estimates for nirmatrelvir against standard of care, remdesivir against standard of care, and molnupiravir against standard of care. And here, our recommendations are mostly based on the outcome of admission to hospital. So moving on from there, not only did we have the magic app, but then it's like, okay, we still need to get these guidelines to people to use, to understand, to apply. And so here, this is just a look at the clinical practice tools that we also focused on. Formal guidance, we have also a PDF version that's on the website in addition to the BMJ version and the one on the Magic app. We have a toolkit, which is a PDF document on many different types of comprehensive tools and algorithms for caring for patients with severe acute respiratory infection. And we developed posters on how to use the various new drugs so they were used safely. Right patient, right dose, right time type of approach. And then I wanted to highlight a collaboration we have with ESICM. This is called C19 Space. And the C19 course that they developed for the EU during the peak of the pandemic has now been transformed and aligned completely with WHO guidelines and recommendation, and is being made available to clinicians in low middle income countries. What are we still working on? Again, it's a lot about this transforming of guidelines now into clinical care pathways, and the one that we're trying to focus now is clinical care pathways for better management of acute respiratory infections. And so here is our care pathway. So C being confirm, and in this case, it's confirm, COVID or confirm influenza or whatever other respiratory pathogen may be circulating. A is assess the severity, and here with the different severity classification systems that we have. R is responding with treatments and how we're going to link our materials all together and different tools. And E is to evaluate how patients are doing and then titrate and tailor treatment according to that. So if I go back to the initial questions that I raised, do we apply indirect evidence at the time, at the beginning, when there's so much uncertainty? I think we had to. If we thought that COVID was similar enough to other viral pneumonias that required, some sort of oxygen therapy, some sort of advanced ventilation, things changed in the way we did practices. But yes, we did at the beginning apply indirect evidence and use that. And I think that was reasonable. We didn't do that, however, for treatments in the sense, and for the supportive care, I think that was common. For the treatments of antivirals, we had to wait for new drugs to come out. The repurposed drugs, we also were careful with that there was sufficient RCT evidence to evaluate whether or not they should be used. So we always recommended use under randomized controlled trials until there was sufficient evidence to say yes or no. Should we conduct clinical trials? Of course. This was the best way, and I think that is the biggest learning from COVID-19, the ability to do large-scale clinical trials, enroll lots of patients, and get to some answers. We don't know everything, but we do know a lot more than we knew at the beginning of the pandemic, and that is really great gratitude we have for all the trialists that conducted these trials during the pandemic. It's the only way to find, well, it is the best way to find truly what is efficacious and safe. How about synthesis and interpreting evidence using standard methods? And here I am talking about grade. For me, it was much more important during this process that we really did use a transparent and trustworthy approach. There was always people who are questioning WHO guidelines and WHO recommendations, but I felt for the ones that we were working on for treatments and clinical care, with a transparent and trustworthy approach, you can show why we did it and how we did it. And things changed, and so the living approach allowed us to reassess evidence at the right time, and I didn't talk about it today, but that's how we approached the monoclonal antibodies, which first we had recommendations for, and later we had to change. And just so you know, the WHO pre-qualification team is a really important team that actually looks at, from the regulatory side of new medicines, and they require grade-based recommendations to trigger regulatory review. And many countries in low-middle income country areas, low-middle countries use WHO pre-qualification to help them put drugs through their regulatory system. So these are countries that don't have strong regulatory groups. And do no harm, risk and benefit at the bedside. I would say, yes, fight the urge to give unproven interventions as compassionate use because they actually may cause harm. We know there was a lot of unproven use of various repurposed drugs throughout the pandemic, and we know that still exists for other indications. But we also know you can cause harm, and use a resource and put people at harm when you don't know if it's going to provide any benefit. Oops. So what's on the horizon? For us, it will remain imperative to provide timely, trustworthy clinical practice guidelines during health emergencies. A living guideline is a successful approach, but I have to say it requires a large investment of resources and time. People hours, and I'm going to show you in a second how many people hours were involved with this. So to keep it up on that pace is I think, is impossible. So it really requires prioritization, what evidence is emerging and what really will impact clinical practice. We are committed, though, to continue to develop such guidelines for other emerging and re-emerging infectious diseases, and this will look at evidence as it's generated, pathogen-specific, host response-specific, and supportive care interventions. But the pace will depend on the public health need. And I think I will end here. All the people that were, and I probably have forgotten many people, but steering committee members at WHO, guideline development group members, and I know that list is not complete, the rapid evidence appraisal groups, the REACT working groups for each of the meta-analysis, the McMaster LNMA team, and the clinical chairs, the external reviewers, Professor Andrew Owen, who's actually provided us with expert pharmacology input into all of our guidelines, and our methods resource team from MAGIC, and I've already highlighted their names before. So with that, I want to thank you for the opportunity to share with you our experiences on living guidelines.
Thank you very much. For problems of time, we don't have to have questions, so we have to move on to the last speaker, the last but not the least, my friend Tobias Welte, former president of the European Respiratory Society, well-known clinical scientist, and readers of the book of my friend Gianrico Garofiglio. So that's you. The podium is yours.
Marco, how many time is left? So I think I make the Jean-Louis and make it with 50 slides in 10 minutes. So, well, I'm the last speaker here, and I'm an old white man, so I will present you more of philosophical view on the question what we have learned. And first, this is something we should have learned in the beginning. Corona has not been the first pandemic worldwide. We had some pandemics much more worse. And I focus on the plague
When the plague came to Europe in 1347, mortality regionally was 90%. And this stayed for years. And if you want to read something about this, Decamerone from Giovanni Boccaccio still is the best book about it. And if you read the sentences, you will say, well, this is like COVID. Yes, people did like in the COVID area. What you can see here is a face mask. A face mask was not effective against Yersinia pestis in any way. It was a totally wrong hypothesis why this came up, but later on, during the flu pandemic, and please be aware, the flu pandemic killed more people than the First World War. It was terrible, a drama. During the flu pandemic, face masks had been investigated, and they were recommended on the west coast of the United States and not recommended on the east coast. And the flu mortality was 10 times lower on the west coast than on the east coast. This is not only due to mask wearing, but masks played a really big role. And even you read other things, masks were effective during the COVID pandemic. SARS-CoV-2 is an aerosolized infection agent, and mask wearing was effective. But one of the major problems we had in Europe, we did not have enough masks because the whole production was moved to Asia decades before, and when the problem appeared, we had no production sites. And this is one of the main learning points for the future. For everything what is essential in medicine, we need production sites in Europe. We need production site in every state to can use it when it is necessary. Well, the second, what we learned from plague is isolation is helpful. With the so-called plague hospitals, mortality came down from 90 to 30%. And the same had been done during the COVID pandemic with the lockdown measures. More effective in Asia and Europe than in South America. Well, if you do not follow the recommendation, there's no really beneficial result. One of the major key learning measures from COVID is you need to be organized. This is the Paris Black Opinion from 1348. It's a very interesting book. Everything in it is wrong. The bug is wrong, the mode of action is wrong, the therapy and the therapeutic options are wrong. Nothing really is true. However, it was the first attempt to bring people together for a standardized procedure to find a pandemic. And this is really, really a key issue. Strategy must be communicatable in a comprehensible and consistent manner in a country, but also between countries. One of my experiences, I started with a plane in Paris without a face mask. And when we passed up in the air, the German border, we had to wear face masks. That's totally rubbish. And this is something which is not explainable for people. As more diffuse you are, as worse the reaction in the population is. And this is something we have to talk about for the future. One of the major mistakes during the corona pandemic was with regard to children. children never was the reason for transmission. Children had a very, very low rate of severe disease and mortality. Here's the CDC data. And when you see a severe course in children, it was multi-system inflammatory syndrome, PIMS. But here are the data, 200 cases in the US, 6 million infected. It's 0.0000 something. No reason for lockdown in children. And we now know all the, it's called the collateral damage. I hate this word, but children are back in school learning, psychiatric diseases had increased, mean body weight had increased, adjusted by 6.7 kilogram, which is a mess. So lockdown never was right in children. And there is a secondary complication we not very often talk about. We now have a kind of relapse of microorganisms, more viruses, RSV wave in more or less all of the countries in the world. And this is a very good example. Streptococcus pyogenes infection, Strep A, all over Europe, more septic cases. And the reason is the decreasing immune response in children, which is in part caused by the lockdown measures. So during the first days of COVID pandemic, in German television, I only have seen virologists and epidemiologists. And this was a mistake. You have to talk to everybody, also to those who are taking care for patients, but to psychologists, to patients, to scientists in social sciences, to get a better picture of what could happen. And this was not done. The good messages. I showed you plaque. The bug was identified more than 500 years after it arrived in Europe. And the first treatment was 600 years after it arrived in Europe. SARS-CoV-2 was identified in between 3 weeks. And the first treatment, antivirals and vaccination as a prevention measure, started in between a year. That's fantastic. And we can be all very, very proud to live in the 21st century. That's really, really something we achieved. This is Paul Ehrlich's lab here in Germany. The first antibiotic discovered, it was salvarsan to treat syphilis, and it was in 1908. And antivirals came up with HIV. That's not so far away. So looking to what we are able to do is fantastic. And one of the main achievements of the COVID pandemic were to get insight into the pathophysiological mechanism, the inflammatory process and the mode of action of the viruses. And this led to develop antivirals, you heard about it, and also anti-inflammatory treatment for the second part of the COVID disease. And these are data out of my lab demonstrating this hyperinflammation. And you know dexamethasone, you know baricitinib and others. But if you look to the data, this is a reduction in mortality by 3 to 5%. It's not groundbreaking. And it tells you we still need more drugs, more drug development for the future. Still room for improvement. Vaccination. I think the vaccine sector is the one which benefits from COVID more than every other one. There are enemies. This is an old story. This is out of the smallpox, the anti-smallpox advertisement. In Germany, it was in the southern part, in Baden-Württemberg, where there were real enemies. But smallpox vaccination was a real success, the last case in 1979. And I will not show you the data, but SARS-CoV-2 vaccines work. You can be infected even you are vaccinated, but the likelihood to be severely ill is reduced by 99%. Fantastic. However, you lose immune response over time, the elderly more than the younger, and men more than women. This is not really this is not really what we want, but how it is. And there is immune escape for the new variants. So infection is possible, but severe infection not. And it has been shown that a second booster in patients at risk improves survival and prevents severe disease. However, with Omicron, there are still patients at risk. You can see these groups here. And Marco, you said several times, Corona is gone. No, it's not gone. It's still there. And it will stay. And it will affect those who are at risk. And we will see severely ill patients, and we will see patients die. That's how it is. One of the major learning points for the pandemic is it's a global pandemic. If you fight it in your country only, it does not help. If you fight it in Europe but not in Africa, it does not help. New variants will fight back and come to Europe and affect the healthcare system. So we need global approach to fight things like pandemics. And I can tell you a very nice paper in Cell last year, which looked only in the Wuhan region to possible new pandemic viruses. And they found 28 ones which have a pandemic potential. And you can be sure the next pandemic in a global world will be there in between 10 years. So we need to learn something. That's something we learned. Viral load in wastewater. It's a very easy method to measure the intensity of the pandemic, and it's cheap. And we will modify this and transfer this to other viruses by sure. So finally, COVID will stay. It will be the new flu. But unfortunately, flu will also be there. So we have more viruses. And we will see severe cases, and we will see remarkable mortality. The next pandemic will come. So we have to prepare. And I showed you, we had plague, we had Spanish flu, we had swine flu. What did we do? Nothing. I was part of the swine flu post-pandemic committee in Germany. We had a very nice recommendation paper. Everything has been written down. 90% of the things which are important for COVID are in the paper. But what happened? Nothing. It was for the waste paper basket, but not for being active in practice. Well, I started with Giovanni Boccaccio, because I love the Italians, and I will finish with Albert Camus, The Plague, a very nice book. And I want to advertise you to read it, because if you read it, you think immediately, oh, there's COVID, that's not plague. It's absolutely the same behavior like I recognized during the COVID pandemic. So that's how mankind is. That's how people are. Nevertheless, we need to learn something. Comprehensive strategies, looking to the benefit of what we do for different populations, and research, research, research. In basic research for developing vaccines, developing drugs, in clinical research to see what works and what doesn't work. And with this, I hope we will all see a COVID not free, but a less COVID intensive summer to breathe deep and have fun. Thank you very much.